we have a quorum yet? We do. Hi. Hello, everyone.
Hello.
This is Blair. Hey, Blair. How you doing? I'm good. Hey, well, you know what? Since you're there, we'll start off with introductions for you, if that's okay.
All right. I'm Larry Trump, living in Williams currently, and happy to be back in Manhattan.
Perfect. And my name is Ben Matthews. I'm the chair of the ACMM currently, and I am a patient and an advocate.
Cheryl Smith, I'm the vice chair. I'm a patient advocate. I'm a director for Compassionate Oregon, which is a patient advocacy organization for medical marijuana. And yeah, that's really relevant.
I'm Mark Richards. I'm president of the board of the MS Society of Portland, Oregon, and I'm an advocate.
I'm Sandy Burbank. I'm the executive director of Mothers Against Misuse and Abuse. We've got 3 clinics in Oregon, and I'm also a patient.
I'm Sarah Bennett, co-director of Human Collective, business consultant, and patient advocate.
I'm Jerry Lehrberger. I'm a physician from Ashland, Oregon. I sit on this committee and I chair the research for medical research, medical research.
Carmen Nichols, I'm the manager for the medical marijuana program.
I'm Aaron Russell. I'm a program analyst with the Oregon Medical Marijuana Board.
I am Tracy Canella. I'm the former section manager for OMP. I'm helping out until they replace me.
Todd Delato, horticultural scientist, public policy advisor and industry consultant, CAN research, education consultant in Corvallis, Oregon.
Megan Lockwood, operations manager for the medical marijuana program. I'm Maureen Russell. I'm also a program analyst with the OMP.
Hi, I'm Steve Wagner. I'm the Center Administrator for Health Protection. So I have this program as well as drinking water and radiation, as well as now Tom Murray is going over the L6C. I'm director to manage the dispensary program and am the point person for public health as it relates to the implications of retail and medical marijuana.
Same.
Thank you.
Yep, you're good. Go all around. Yeah.
I'm Chelsea Hartman. I'm here to get a little bit more information.
I'm Mason Hartman. I'm an actual caregiver and grower. Just trying to get more information on what's going on.
Pete Kramer from Mercy TV, patient advocate and grower and consultant.
Ryan Eccles, grower and advocate.
Melissa Rivera, I'm a nurse and I'm also an advocate.
I'm Emma Rizzi. I work for Mama. I'm also a patient.
I'm Brooke Smith, dispensary owner. Carlton Crawford, affiliated also with Portland Medicine Hot.
Brian Wilson, advocate, activist, grower.
Craig Pryor. I've lived in Portland all my life, mostly in lower East Portland, and I'm a grower, patient, and caregiver. Have been for 5 years.
Rachel Jones, owner of Club Sky High, also a patient, caregiver, and advocate.
Louis Stokes, owner of CanGuard Security. We do specialized security systems for the campus district.
Okay, great. Thank you all for coming. I really appreciate it.
Yeah.
Right. I'm sorry. He's sneaking by me.
I'm Gabby Tomato, case processor for the OMP.
Thank you. Perfect. Okay, well, I guess the first step is wanting to review and any amendments and then an approval. So are there any adjustments or amendments people would like to make to the quarterly ACMM meeting minutes for December 10th, 2014?
I wasn't at the meeting, but I'm reading, I'm hoping what I printed out matches the other one, but at the bottom of the open discussion and the action items, there's the benefits of OMP list will be crafted better language. I think that should be changed, I'm just guessing, the benefits of the OMP.
Could you give me a page number? Sorry.
12. Oh, it isn't 12, I think. Yeah. 12. Down at the bottom of the action items. I think it should be will be,
I'll fix it.
will craft better language.
Todd, you had your hand up also.
Yes, on the first, well, it was the first page. It's different on the
See you, exciting.
Okay. Well, there's a few places where it occurs in here. The first place is on the first page, summary of meeting motions around creating a bylaw subcommittee. I never volunteered for that committee, so.
Oh, I liked it. I
Yes.
really off the committee.
It appears a couple other times, and I have that noted on my computer here, but not on a hard copy.
That's not that in.
Okay.
Any other people with any other comments? Or anybody else? Okay, so
Make a motion, the meeting, the minutes be adopted as corrected.
Okay, great. Can I just let me add one more thing real quick, and then, yeah, and I just want to find it here real quick. Did I circle this? Oh, yes. On page 12, the top 3 benefits get from Aaron. That list, we should actually have that incorporated actually in the actual list of minutes.
Yes. I would think from the images.
Yes, from the images, just to transpose it into the list that we had, if that's okay. And then if you wouldn't mind also sending that list out, or someone, someone sending that list out separately as well, all those, and including maybe if it was approved by Kiwanis and Stickles, that it also be sent to possibly some of the staff, or at least the key people would know what the ACMM priorities lists are.
I'll second Sandy's motion.
Okay, all those in favor?
Aye.
Aye.
Objections?
Is that the motion to?
Approve the minutes, yeah, yeah. Any objections? Abstentions? Okay, the motion passes unanimously. And, ooh, I'm ahead by 8 minutes. Now, so next we have the uninterrupted administrative reports. First, we'll start with the program updates, and budget.
So we currently have 24 permanent employees. We're recruiting for 3 positions.
Can we, just 1 second, let's pull that. Are you reading off a document?
You guys will have it in the paper.
Oh, okay, thank you.
Just one.
Thank you so much.
So we currently recruit for 3 positions. One of them is assistant manager. Tracy got promoted, but she's still assisting part-time in a few projects. One is this committee that we're training Gabby as the head of the to be a backup in case we don't get the position filled in the ACMM meeting. The other positions are the public service rep 3, someone to help assist with answering the phone, and the law enforcement liaison is the second position. We interviewed, and we have an interview for the section manager assistant, the other position. Yeah.
And, sorry, I interrupted.
Take note of that. So Aaron talk about staff.
I've got a printout in here, right in your folder there about statistics on this as of late last week. We've got 70,559 home and key patients currently, 35,137 caregivers, a little over 46,000 growers. Number of registrations or applications where a patient lists him or herself as a grower, 37,408, and the number of registrations we've received where a patient lists someone else as a grower, doesn't have a grower, is just under 35,000. There are currently 1,666 physicians who have a current patient on the medical marijuana program. You can see the out-of-state participants. It's about a little under 17,000 patients, 1,700 patients, 616 caregivers, and 548 growers. And then the condition count, as always, severe pain is the most common condition, and 65,387 patients listing that on APS. Spasms, we've got 18,456 patients with that is a qualifying condition. 9,525 patients indicate nausea. Cancers at a little under 4,000. PTSD, a little over 4,000. Seizures right around 2,000. Cachexia at about 1,200. Glaucoma about 1,100. And HIV/AIDS about 750, and fewer than 100 with Alzheimer's. And you can see that although almost 66,000 patients listed here have severe pain listed as a qualifying condition, only about 38,500 list that as their only qualifying condition. And then we've been asked to report the number of folks who only have PTSD listed as a qualifying condition, and that's just under 1,000.
Okay. So I want to give an update on some of the program projects that we're working on to help, help the patients and educate the public, and give a better understanding of the overall program. So we've created a free brochure, which has been printed and some have been sent out. And also we brought some extras if anyone want to take some with them. Their page has been created and changed. We haven't had too much feedback from that as a negative, so we make it a lot better. The handbooks, we have 2 handbooks. There's one of the program handbooks that we created before, we revised it, added a few infographics in there, changed and updated some information, added PTSD in there. And then we have another application handbook that we created. That one will be ready in May. Give instructions on how to apply for the program, walk them through, show them how to fill out the application, what's needed, examples of the reduced fees. The proof to show that they proof that this is what they qualify for the reduced fee. That's it. And this has been helping us finish up on those this there. So you guys got the budget summary in advance as we promised. Once we got it finalized. Is there any questions in regards to the budget? I think this is much easier for you guys to understand what the expenditures are, break them down.
Do we have the standard financial report?
This is what we're gonna see now. This is the financial report that we're now seeing.
So all the work that we did to create that expansive report.
What report?
The report with the graphs and the.
Are you talking about the report that I usually provide?
And the projections and the history, yeah.
The one.
The report that
The report that I used to provide, but what work, you said something about the work you guys did.
We've been working with you for 7 years now to get an adequate financial report, and we finally came really close the last couple of years. And that report that you've been giving us with the graph, the projections, and the trends and stuff, we worked a lot to help communicate with you guys to figure out a good reporting format.
Okay, so that report that I was providing wasn't because of you guys giving me anything. That was established by our program support manager, and that was his tool of how he presented that to the management team. And
there was some things that wasn't correct and that we were providing, but I can still provide you with the graphs, if that's what you're asking. And I thought you wanted something more broken down, and this is what was approved by our fiscal officer to share. If you want those things, I can go run that through and see if we can still provide those graphs. That's what you're talking about, some of the reports that I provided where it had on the second page the revenue.
Okay, well, what we'll do is we'll because I guess this is officially uninterrupted, right? So when we're done, do you have anything beyond this, or would you like us to address these conversations now? Would you like to wait and finish your report, or would you like to?
I think this is all that you have to report
Okay.
on.
So then I think.
The only last thing is the travel thing.
Well, we're aware of that, so if you need me to
So I'll
go.
just tell you what the per diem rate is for Portland. It's $13 per night for a hotel and $66 for meals. And you guys should all have a updated electronic version of the spreadsheet to submit your travel claims on. If you don't, let us know so that we can get that to you and provide it in here, because we usually do it electronically, so.
So then let's, so I'd like to make a motion that we actually have also provided the previous version of the financial reports. I would also like to take a minute, or so let me put that on. All those in favor? Aye. Objections? Aye. Are you objected? Or for?
Aye is yes.
Yes, for, okay, okay, good, we're all for it. So, any, no objections, no abstentions? No, okay, so this motion passes unanimously. Ken, while we have a minute, since this is an entirely new report,
Well, because you guys were asking for a breakdown, you kept asking for some of the breakdown to understand where this business was going and what's going in and out, so this was a solution to that.
No, that's great, and so can you just, so can you help us, since now, we're used to a different report and have it for years now, so let's go over this one real quick. So let's go over this one report if we could, and just take a minute, and if you could show me where your, say, just where the operational budgets for your operations and for your
Expenditures for us to.
program. For operations program.
The expenditures is that, the second bullet there.
Second bullet is.
I mean, not second bullet, the second section, it says revenues, top, that second grade, areas of expenditures.
Yep, and so it's a budgeted expenditures, it doesn't have a budget, it's a budgeted.
That's
the expenses.
Our actual expenses.
So your actual expenses, $2 million, yep. And then, and OIS charges.
And OIS is Office of Information Systems, so that's what they provide service to run our database or fix the equipment. And then the other programs support, the other public health programs, the other programs that we have transfers out to support for public health. Those 7 other programs.
Yes, I think what this is a concise summary, and I think we need more information in order to advise this program properly. And the financial report that we had been getting up until 6 months ago has been probably the closest to adequate that we've had. And the purpose of this advisory committee is to advise the program on administrative aspects. And if we're not provided with the information we need to understand what's going on with the management and administration of this program, then we have no ability to advise you. And I'm a little frustrated that every time we come to meet here, it's as if you have no memory of the things that we've agreed to and the reporting and everything, it seems like we're starting from scratch. And then you tell us, okay, well, next time, and it's, we really need to be providing you with good advice based on good advice, information you provide us, and I'm just.
I don't agree with that. Can,
Do you mind if I ask a question on that?
Please.
Let me understand maybe the detail of what you're after. Are you asking to advise on hiring of positions, how much money is spent on travel? Supplies or materials?
Specifically, one, to know that. Just think of yourself as that if you were advising on a board of directors, advising a company, or anything, right? If you were provided with this, would this be adequate when you're one of two job descriptions, as our board was to advise on the finances and the budget? And so we never actually get a budget, we just get a dollar amount. So we don't know how much is right with this, how much is being spent on payroll, how much is being spent on payroll, how much is being spent on leasing office equipment versus buying, how much is being spent on third-party contractors, how much is being, all these basic, very valuable questions, I think that you could see would basically define how it's operating. Like we know, we've been short-staffed for a very long time, and when we get a good staff person, like say Tracy is an example, she's moving somewhere better. Best person we've had, bar none, is moving, and that's good because she got a better job, but probably she got a better job and a pay raise, which wasn't available at this one. And so my questions are, at all these levels, do we want to micromanage that? No. But would it be at minimum good to know how much is dedicated towards payroll, how much is dedicated, so we can actually, my understanding was, when I came on at the very beginning, and I think all of our understanding, when you read the bylaws, that was one of the fundamental items, was
personnel services right here, flanked out, that's personnel service, that would be.
For me specifically, it's the other funds that are provided for the other public health programs. It's not defined on how much money is being allocated per program that's out there. And that is part of our, I think, responsibilities to advise on the fee structure and how the fees are in place and what they're funded. And, in essence, it's difficult for patients financially more often than not. And so that is probably one of our biggest tasks.
So that was broken down in the.
So I know I'm behind you, I'm really sorry about that. So let me move over here just a second. So, I talk much better standing. I think that's a good point. And I think we'll get the other governors, it's in the governor's budget. It's a legislative item that says exactly how much is going to go to each of those programs. This program doesn't decide this. This group doesn't advise that other than advising the legislature.
Correct.
Because it's all set forth by the legislature how much is going to those other public health programs. That was a decision that they made as far as how the fee structure needed to be to basically fund those programs. So we have no real direct control over that.
Oh, we understand.
But that's we can print out what the governor's budget is and what's
Usually it's provided in your, we can broke those down, the seven programs, and what the amount that was allocated to each one of those programs. And unfortunately, it's not in here this time, but, no. That's easy to print out and
Let's take it directly from what the governor's budget is. It's a public record and is out there and basically highlights. So I think that's.
I think if we were to look back at the reports we used to get from Chris Guru.
Chris Guru, that was the best.
They were the best reports, and then all of a sudden he was gone, and it's been lacking ever since he left. If you would look at those reports he made to us, that's what we need, that kind of information.
And since Chris left.
And I hear you on that information, but so I'm trained as an epidemiologist, and so for me, data is always about what is the question you're going to ask and answer. And so that's what I'm trying to understand from all of you.
So the question we're going to ask is we're advising, our job is to advise on the fee structure, one of our things. It's impossible for us to advise on the fee structure if we don't know where all the money is. I just found out the last meeting that there's another agency that we're funding. that I didn't even know about. They didn't even know about it, or didn't explain to us until that moment. So there's a feeling financially of being left in the dark, because I've been requesting more detailed information ad nauseum for years since I got on board. And I can honestly say I yet have something that I can take that information, parse it out, and say, look, these are the areas where our patients, the most needy, need help. And these are the statistical numbers, the facts, the dollars and cents that show that, yes, this is good, but do we want to provide this on the backs of the sick and dying? Do we want to fund this service? Then we can actually directly go and have a conversation with the legislature, have a conversation with you, hopefully, in a perfect world, get you on board and excited to help make those changes. And I understand you don't have any direct control, the legislature does, but I think we have, and please don't hear my frustration saying it's just frustration because this has been going on, and it's a dance that has never been resolved.
And I think level of detail is important. So, I think if you take a look at this, you can understand where a significant portion of the fee money goes, right? Other public.
No, I don't, that's what I'm saying, I don't know other public health programs.
Right, so that's the.
What other health program? And what amount? So one health program that's helping people that are sick and dying in another area, that's great.
We'll get you that. So that's drinking water, it's CMS and trauma, it's C-Care. So we'll get you those figures. It's set forth in public record in the legislature, part of the legislator's budget, and that's what those other public health programs are. And
you can understand how frustrating this is, and we come time after time after time after time with the same complaints, and we still don't have what we need. It makes us feel like do we really matter?
So I'll I don't know how you have these minutes, but I was fairly certain that you provided out that piece that said how much goes to drinking water.
Yes.
Well, that's why we're shocked he did, and there was a new item we didn't even know about that was never disclosed to us. And so that's, I guess what it is that every meeting, I would like, just like every meeting when I was part of any board that involved anything to do with money, I had all of my financials in the way that I wanted to see them without complaints, especially if I was key in advising on that, and then we could take that data and say this and this and this, why can't we, or can we do this? And you'll say we can't because it's legislatively, and then we go to the legislature and say we can have an effect on this, we can transfer more to payroll, or we can do more of this, or we can and then we can go work together to assist you to get the funds that you need, put in the right way, and even better, reduce the cost for the sick and dying people. And that's the end goal. Is that a lot of people I know that are still to this day not part of the program and risking prosecution at this point, right? And then soon, I know Measure 91 that won't be, but for the 18 to 21-year-olds, that's thousands of people on this program that will be needing that too. And if they can't afford it, it's a crying shame that they'll go to prison because of those costs, because drinking water.
So I will. So we'll talk about what we can get you and work with our PSM and our fiscal people. I will ask you though to leave the operational management of the budget to the person who has to run the program.
Or absolutely, but I thought we were advised on that.
And that's where I guess maybe we have a difference.
Okay.
Is that advising on the program is at a different level of the tactical, how much money is in personnel or travel or otherwise. So, that's where I'm at. And I don't see that as a board's role. It's not something that's expected.
I don't either.
Kind of Oxley sorbing. It's not, what's generally expected. So I think we can give you those broad figures about this is what goes to drinking water, to others, so you have a perspective on what the funding is.
So I'll let it go. What my question is though, once again, is that what's the harm of providing that information? Like you said, it's public
The harm is
information.
additional. It really is the additional work in creating a budget.
Excuse me, Emerson did right now, but we just provided that in a lot of these meetings. So we don't have it this time, but it doesn't change. It's the same amount.
That's where
it doesn't change. It's the same 7 program, the same amount. The only one that was increased was the C-Care. And we provided that in one of the last meetings. So Aaron will get it, it's ready and available right now.
Well, that's just, I mean, I think you're addressing just a couple examples of things we brought up. How much money goes to other programs and travel expenses and stuff.
Right.
Those are just two examples, but.
But there's only so much this program does.
Right.
We
And we understand that, as Steve pointed out, that all these things are public record and we can access them. But to do public records, freedom of information requests and do all this research to prepare for a meeting is a lot of work to ask for a volunteer advisory committee. And this program has the statutory responsibility to provide us with the information and cooperate with us to help advise you on the administrative aspects of this program. And on several occasions in history, we've come to kind of agreements on the information that we need to be reported. And I was told that financial report is kind of a plug and play. It took a little while to set up the graphs and the queries, but it's plug and play is what my understanding is, and it doesn't take any staff time to create that report.
That you work this out, let you know what we need. It sounds like you're available and open to getting us what we need.
I decline, because I now have provided that ad nauseum. Please look back at any of the minutes over the past 3 years about what we requested. Look at the past information. Look at the request. This is, like you said, Juana, this is not something new. This is not something new at all. This is new. This is new, and now consolidates an 8-page document into a half a page or 3/4 of a page. And what I'm saying is that my request is that if you want to provide that, that's great. We worked really hard to get something, and that is now abandoned and not even communicated and just told that that's the case.
I think for the ACMM, we want to be successful in devising this program. And in order to do so, we need all the tools necessary to make that happen. And if the report was going to change, it would have been better to have communicated that to us before the meeting.
I did. I sent out an email and explained why we didn't have a report and that it was going to look like this and this and that I got from the fiscal officer. And I did send it, and we sent this in advance. And no one said anything in advance.
You did send it in advance,
and I also explained before I sent it why it was different and what was happening with the legislature. So I did do that.
Thank you.
So I'm absolutely open to sitting down and having that discussion about what's the data that drives that and what's available. And I think that's about bringing in our fiscal officer because we're pretty light in terms of fiscal people to pull reports. Right now we're pulling through the legislature and trying to develop out our bill and answering questions about what the fiscal impact of every bill is. So we're pretty. That sounds like excuses. I'm sorry. But I got priorities to try and handle the bills right now and be able to tell them how much it's going to cost if they're going to change the whole medical program, the retail program. So there's a lot of moving parts. I want to be providing you data that's appropriate for the decisions you make. And so I'm willing to sit with Juan and I and our fiscal person with the small group to found that out.
I'd like to suggest and possibly make a motion that Todd and Ben get together with these folks between now and the next meeting and see what we can work out in a kind of informal setting. Would that be, would you be able to do that?
I will second that.
All those in favor?
Aye.
Objection?
Aye.
I have abstentions.
Let me ask you a question.
Passed unanimously.
Does this committee have any input on how much money stays in OMMP? Or is all that money spoken for by legislation?
It's spoken for by legislation.
And what do you recommend in terms of this committee giving some input into that, or how does one go ahead and change that formula?
I think individuals, whether it's this committee, let me say it differently. So this committee is formed for a particular purpose, to provide advice. You are all individual members of the community. Introduce yourself many times in the various roles that you play. I think absolutely, you should take your prerogative in terms of talking with your elected officials, okay? I know that's kind of a broad answer, but you always have that flexibility. And I think that the information you have in terms of the other public health programs that this funds will help you with that piece. What I will tell you is, as a public health person, is oh my gosh, do we need to make sure that we still have a public drinking water program and EMS and trauma and the other things that this funds right now. And yes, decisions were made at some point in time before I ever came to Oregon to say we are going to use medical marijuana card funds to fund those programs. But those are important public protection programs too. So there has to be some money.
I think it's really sad that that this program, which funds other programs, is always running short staff. We get somebody good in there and they're gone, and it's kind of been like that for a long time. This program should never run short staff. I mean, why wouldn't you take care of this program that's such a money maker? I just don't understand it. It's very sad.
Sandy, we were fully staffed for the last 3 years. We have a while back, yes, we were staffed, but in the last couple of years, we've been fully staffed. Tracy's the first one to go in a long time. I think,
But what I just heard was that you don't have the staff resources to provide us with the reports and information that
I
we
didn't just
need.
say that. I didn't say that.
You said that a few minutes ago.
So
You said it.
unfortunately,
I didn't say that.
I would suggest that external influence isn't necessary. So yes, there are 103 vacant positions in the public health division, okay, out of 600 plus. Okay, so every place, whether we're talking about our healthcare facility licensure or drinking water or others, we can work really hard internally to try and deal with that. But I will tell you, good people will always leave. If they're, I don't mean to say that good people don't stay too, but if you're hiring somebody and thinking that they're never going to leave, then you're never thinking that you're going to develop people or they're going to grow or otherwise.
We're all for that. That's not the conversation.
So we know the funding for these other public health programs was just for that biennium. Does OMMP or you to go higher up the level, do they have pull with the legislature for that to happen or not? And if so, what are you doing?
So,
I mean, it sounds like there's
I will
a little
give you
conflict there.
my line, which is the governor's budget is the executive budget. So that is my budget that I have to speak to. Okay, and so the governor's budget has those funds from the medical marijuana program going to those other public health programs.
So
So there's no input from the state agencies then?
There is input.
Because it all happens secretly, we find out after the fact
Once
last
the
year.
governor's budget is set, that is the governor's budget.
But up until the government budget session, you have input into that.
We provide recommendations. Yes.
So how come you don't ever see those?
Because those are.
If we're advising you on that, why don't
you won't.
And so what I'm asking is why do we exist? Why does the advisory committee on medical marijuana, with its mandates,
Because it was
exist?
written into the statute in 2005.
No, I mean, my point is, why are we here if our base, is one of our base existences is to advise on this, but that we really don't. That's a one-way street. We advise and then we wait and we're told
So,
what happened.
can we just say though that just because.
Big waste of time.
Yeah, I don't know. I don't think that when I provide advice to my boss and she doesn't take it, it's a waste of time.
But if your boss
doesn't necessarily.
But if your boss doesn't talk to you and tell you what's going on, and you find out after the fact, that's a different experience that we're having. We're having a much different experience than giving input and then you not taking and saying, thank you, but we have a different reason, we're going a different direction. Great. That's communication, that's valuable. But coming here and then and then being told that you won't be privy to the conversations that you're supposed to be fundamental in having and supporting, that you're going to go talk to people privately and have those things to try to promote the budget, but that we don't have any say or conversation in that. We'll just find out after the fact. Just like you mentioned in Patson's conversation, they're talking about restructuring and whether there even is an order medical marijuana program. And yet, this right now, we're dipping into the dialogue between the OHA administration. So I'll ask you the right question. What are those conversations that you've been having? Can you keep us know what that looks like? What are they discussing? What are some of the plans or proposals that you're asking to submit to the legislature? What direction are they being going? What are the conversations being had?
I'm not sure Steve knows any more than we do.
No, but he was saying that he is having to prepare reports, right?
So there are 40 plus bills on here.
Right? Very much.
So, and you're all aware of the Joint Committee on Implementation of 91, and that many of those pieces are going through there, although there are also bills that are being heard outside. So the piece on, I heard of the bill number on the limit on 450 patients. And that went through healthcare committee. There's a bill today that I need to be present for, which is about posting of warnings in dispensaries related to harmful effects of pregnant women. Has some issues in terms of the way the language is, but I don't think there's a single person that can tell you how this is playing. Right? How many legislators are there? How many people are involved?
So Steve, if you were to advise us on, we have concerns again about, of course, the pay structure, what people have to pay to get a card, and funding the money, moving the money into other programs. I think I could safely say we do about that. You know, we would like to see the cost, the $200 lowered, as always. Yeah. What would be the best way for us to approach that? If we advise you guys, then you advise the legislature, or do we go directly?
So we advise the legislature oftentimes through the governor's office on the budget, because again, it is the governor ultimately has to make the decision on what the executive budget looks like. Having said that, that's the governor's budget, and the legislature still has to pass that budget through Ways and Means and then to the House and the Senate. So they always have that authority to make decisions about what the allocation of funds is. On the back end, then, we as a program are trying to think of a different word than stock that's less colloquial, but we are basically in that place where we've been told that we're going to use this source of funds, not only to fund the program, but also some other public health programs. So those end up being our fixed expenses, you know. And from that, then, you are in the position of advising an executive branch program. You're not a legislatively, you're not advising the legislature, you're advising us. And so we're back on that back piece. You might have been authorized by the legislature, but you're advising the executive agency in terms of, given those parameters now, how do you set fees? Well, now you know, we'll get you know what is appropriate in terms of the expenses, but you see then that our expenses are fixed by program and other programs.
You may not be privy to the fact that when the prices were raised to $200, we were deliberately kept out of the loop until after the vote had taken place. That was an admitted thing. They kept us out of the loop. What did he say? He was worried that we would interfere with the legislature.
And that was a legislative.
What's his name? Who was the guy?
Well, Barry Cass. Well, we advise on the legislature as well.
He admitted that they kept us out of the loop and we did not know anything about this huge price raise. And so, you know, us who've been around for a while don't forget that kind of thing and wonder if that's kind of what's going on now.
Yeah.
The March meeting is a really important meeting because it's in the heart of the legislative session. And our advising this program on the way you advise the legislature
I would just.
is
No, I don't, no, I don't think you advise us on how we address the legislature. Okay?
We can advise the legislature,
Yes.
correct?
Yes.
Yeah.
Okay.
But if it's related to the administrative aspects of the program, see, this is the problem we always run into, is if we want, if we recommend an administrative change, then the program usually tells us, well, that requires a legislative change. And so in order to get the legislative change.
So we're not your spokespersons to the legislature. And I think that's where, so you are all under, I've had a number of people describe themselves as advocates. We are not we are not the spokespersons for the advocates. We are for the program, correct? And for this agency and for the executive branch. And maybe it seems like a distinction without a difference, but to us it's pretty important.
Well, I would say that it seemed like, I hear what you're saying, but it seems like the patients are the program. So I guess what I'm saying is that I hear what you're saying, and I'm saying that our request is that you are, by nature, hopefully advocates for the patients. Because that's why the program exists. And so I understand that it's for the legislature and all these things, but none of that would exist.
And I understand that
we're getting sidetracked a little bit, so we need to move on.
Reach out directly to the governor's office and have a liaison there. And
We can go reach out directly legislatively.
We should do that.
Yeah, obviously.
And then I have a question, is if this program did not fund these other programs, if OMMP did not support the other public health programs, where would the state of Oregon be getting its funding? That's what I would like to know. Because if we can redirect that, then we might have the opportunity of opening a window to reduce the fees appropriately.
And I would suggest that at this point in time, that is a legislative conversation. The governor's budget is already before.
And so, and I understand this is a dialogue between ACMM and the Oregon Health Board Administration. Thank you so much for the administration for being here. I want to start by that. I know you're in the hot seat right now. So I want to first acknowledge you for stepping up and standing up, and it's better not to be in the hot seat, but actually standing there. And so I guess then you know where we're at. And if you can tell nothing by our frustration and passion, it's our passion for wanting to assist the patients. And this program to be better for and by the patients. And so I think we all have the same desire for that. And I know that. And so my request to you, Lex, is what specific ways would the information that you have recently, this is, as you know, like you said, it's 40 different bills, it's moving really fast, all things are changing. You have insights that there's no possible way we can have. And so what I'm asking is that you not do anything that jeopardizes your situation, but to just ask a simple question of, if you were in my shoes and our shoes, what would you do that could make a difference for the patients? If you're in my position, so basically I'm asking you as a person, right, and us as people, both wanting the same thing, to assist this program and the patients in it, and know the changes we're looking to make and the difference we're looking to make for the patients for a better way. What I'm asking is, what recommendations could you give us to more effectively do that beyond the legislature? And what specific actions would you go towards? How can we make a difference? Because I'm personally feeling very frustrated that I'm not making any difference here. I'm just being honest. And, just for me very personally, I feel, I question every time I come here, why? And so, I need you to tell me, what can I do to make a difference? Because I'm one of those people that just talking doesn't really have me feel very good about myself. It's results. And so, what results do you think we can actually have more momentum on? Because I haven't I haven't experienced that yet. That makes a difference for the patient directly.
So let me, a few things. So some of my day is figuring out what I can influence and what I can't. Actually, all of my day is that way. Because there's a great deal that I cannot get done, or that I only have incomplete influence over. Very rarely do problems that I have relate to direct authority.
Yeah.
Right? Most people are doing their job, and it takes little direction for that to happen. I think that a tremendous value of this committee is just that connection that you have with the community. And while we have that on a daily basis as people call in about their cars, or we try and navigate the issues around that, it's still the fact that you've got this connection in there. And so what we get value out of is maybe it just seems completely natural to you because you live it every day, but it is important to us. It's an understanding of how you are a patient or a caregiver or help to work with that community or otherwise. And is everybody still confused about the fee structure? Are there problems with how people are navigating their application? Do we see access issues in terms of patients and physicians? You know, it's some of the things that I guess I'd say it's the things that Tawana has control over and influence. You know, line control over that kind of input is really valuable to us. It's valuable to us as we look at the rules and the processes and procedures that we have to make this a better program. What's difficult for myself are things that we don't have authority over, right? So when you advise us, I don't have authority to tell what the government's budget is.
What would you like advice?
But
that's what I'm asking. So let me rephrase it. I'm asking specific, because I'm a specific measurable kind of guy. So specifically and measurably, I hear what you're saying, and I appreciate it, and I wholeheartedly agree, and I think everybody here does, correct? Yeah, is that my specific measurable, I'd like to know what are those specific measurable things that you have questions on or would like advice on? Yeah. What are they? Or what are the 20? I've never actually had, come say, I have these questions. I've gone, reached out and had the meetings, and thank you, Tracy, for creating a few of those. That made the difference. In fact, I can say that the way that Tracy related to me specifically and us was the first time I really felt like we were part of a team and not on opposite sides of the game. And I really desperately want to work with a team to make those improvements for the patients. And yet I don't know how to effectively do that. And it has me exceedingly frustrated that I'm not making a difference. And I don't, maybe I'm just speaking for myself here, but I want specific measurable ways that we can make a difference for our community.
I've been involved with this. I was on what we call the administrative work group, which existed before the ACMM, and we just kind of did it, doctored kids and put it together. One of the first things we did was take the addresses off the cards. It took 2 years. Still got them off the cards. All the work we just did on the website, that's really important. That's where the patients are going. I have 3 clinics. I deal with patients 7 days a week. They call me at home. They're confused. They don't know what to do. The kind of information I want to get straight is things like, why do we have a drop box out here where you don't get a receipt in the corner, all by itself in a dark little corner? It's almost insulting. Why don't we tell our patients that if you don't have a certified receipt to show you mailed your application in, you don't have any proof that you're okay until you actually get your card? I've been fighting that one for months. Why don't we have that everywhere? That when you send it in, okay, you don't have to say send it certified mail, but you could say if it's sent certified mail, then you would have a receipt. These kinds of little things is what I see our committee can be very actively involved in, and yet when we just did the website overview, I've been working on that a long time, every page, I've read every single page and reread it, but I don't see the other people in the ACM, all of the other people doing that. This is how we can definitely have an impact with the ACMM. I mean, with the OMP, we absolutely can. And yet, there seems to be divergence in what we're supposed to be doing, and I see this kind of thing that I'm talking about, which so directly benefits the patients, is kind of missing in our group, as a group as a whole. And I would encourage everybody to embrace it again. Now, Sarah, you came in and you came in, but, you know, we didn't get a lot of input from a bunch of people, and that website is so important. Now, because you cut down on your hours, our clinic, we're open 5 days a week from 9 o'clock until 5 o'clock every day we answer the phones. Last Thursday, we got 79 calls. And I know you've expanded your call time you're taking, but we're doing a lot of work for you guys just supplying basic information because you can't answer the phone. So as a committee, I would say that yes, all this other stuff is really important. I totally agree, but I think we need to look at the basics of why we're here in the first place and look at all this little stuff. Look at this book. We didn't have input on this book before it was printed. We didn't see this before it happened.
Yes, we did.
Yes, we did.
We
Oh, we did?
did. You got sent to us in the draft.
Yeah.
Well, maybe I didn't.
Yeah.
Okay.
No, and that piece is, yeah, so it was right.
Well, that's all I'm saying, is that, okay, we kind of jumped up to this other stuff, but we're not doing the basic stuff we need to do as a group.
Yeah, okay.
So I hear you on some of the things that we've done well in terms of working on the website and others. I think there's that kind of piece, and we can start to make sure that we're really deliberate about the agenda and closing the loop on what comes out in terms of provision, what we made decisions on, whether it was input. And I do appreciate the openness to really help us to most effectively be there for the patients, physicians, caregivers, because this is going to be, I don't know what's going to happen. I really don't. I don't think, there is no one who knows what's really going to happen until all the votes are counted. And so one way or another, though, this is going to be a big transition for this program, even if it doesn't change. The fact that retail will come to pass will be a change for this program as well. So I think we're going to have to stay really tight in understanding what's going on from your perspective, and think about the ways in which we can do it. We're talking about how we can both be able to process those applications and answer the phones, which is, sounds like it should be a competing influence, but yeah, so maybe there's some of that framing about, well, how would it play if we change this? So I think there's ways in which we can put it to you that also what I would expect maybe is that you might need time to mull things over, talk with the people that you know and you work with, so that you have, instead of just coming here and being asked a question necessarily, but we can try and put together some of that, just as I understand we did with that brochure, or we did with the website. So.
The brochure, to be fair, since Tawana got the position for Tracy, they're working really hard on an educational piece and should cut down the phone calls. And
which I gotta say, when I received my card in there, and I really appreciate that. And that's the first thing I said. I'm like, wow, that's so great. And so what I want to do is, what's the way? Because right now it seems like we end up at opposite ends, and it seems like now more than ever we really need to be tighter together. And I don't know how to get it, so we're working to where you're saying, hey, here's some things we can do, or hey, what are your things that we can do inside, or this is the only scope we can work in, and these are, and so if there's, because I know we all want the same page, we've done that a couple times, and we've had forward momentum in our collaborative. I'm saying, how do we take the one-on-ones that we've had there and take it to this group, so we're effective as the ACMM, and we feel effective, and we are effective to make the difference in the patient's life.
I think we also need to maybe communicate a little better back how we heard you. So, for example, Tawana's working now on how we improve the quality of the cards. I mean, we've heard, I'm sure it's happened in discussions here about cards falling apart or otherwise. So yes, we've absolutely heard this. We're trying to make changes related to that. I don't know if you understand that we're trying to do that or
We
not.
never do
So you
that.
don't know that,
No,
you
we
don't
never
know
do.
you've been heard of it.
Well, we don't have
Right.
input, that's it, so
Right.
if you tell us our project,
So-
we can input
I
that,
did
you know.
speak to that when I.
So we'll just make sure that we're closing those loops and there's more, more back and forth and more documentation about how we've shared at this point in time and what we heard from that conversation back, as well as then what we're able to implement and not implement. Okay.
Is there a way for you and OP to kind of progress other upcoming things so that we actually do have stuff?
Yeah. So that's, so maybe that's just a way of, as you're trying to, I mean, Tawana's trying to do a lot to, her and Megan and Tracy before she left and all the staff, trying to figure out within, what we've got now as staffing to really be able to process. They've got some great stats on how they lower the times for processing the cards. I mean, that's all good, but I don't know if you've even heard the feedback of how they tried to do that and whether that maybe that's pinched some things out. So yes, we probably do need to try and create some of the, here's the projects we're working on. That also give you the opportunity to say, gosh, I'm really interested in this area as a committee. We think we could provide some good input on that.
Yeah.
And work from there.
Yeah.
Is that, so maybe just like the website, Tracy reached out and had you guys come in
And we,
say the brochure.
I
The brochure, yeah.
Kudos, though, I mean, the amount of development that's happened with the education, the website, the brochures, the handbook, phenomenal in such a short amount of time. So thank you guys for doing that. It's nice to kind of finally be at that level. But we're gonna have to stay, kind of vigilant about what's happening with this legislative session. I'm sure a lot of things are gonna change in the next 12 months.
Right, and so what will be, we can put out a standing question right now for next time, which is what are going to be the gaps in education that are going to occur with the card holders? We might not know all of them, but what are we speculating are going to be the things that we might really need to communicate with card holders, caregivers?
The biggest gaps are with the healthcare professionals. They don't know anything.
Yeah.
And I had a bill introduced that just had home health and hospice up and workers and freaking out. They'd never even looked at the law. So even though they have patients they serve that are using medical marijuana.
I believe that while there are quite a number of bills out there, it's likely that all of the legislation will be in only one or two bills that will really move. So it'll all be put together as amendments. So when that will occur, I really do not know, and what it will look like. I will tell you, and for those of you, and I've seen a few of you in the joint committee at times, but I have heard a lot of concern about. Well, let me start with the very first joint committee meeting. They went person by person and said what they're interested in, which I thought was amazingly transparent and wonderful for legislators to go through and say what they were really concerned about. And a good majority of them were concerned about making sure they maintained, I think the word they used was the validity of the medical marijuana program. But there was a lot of concern, and I think they heard a lot of patients, caregivers, and others on this as an issue. So they don't want to impair the program. They are concerned, though, about running duplicate programs. They are very concerned because they heard from Colorado and others about the diversion of marijuana products. They're concerned about the safety of the products. And then there's, also even like there's a Oregonian that had the pictures of the lollipops and the gummy bears. So they continue to be concerned about those products. How they will address that in the context of retail and medical is, I think, still left to be determined. How much will be joined and how much will stay separate. And whether if there becomes, so for example, if there becomes a similar program on the medical side that looks like the retail side, will we need cards in it? So I don't know what to, I I am as uncertain, other than shaking the 8-ball or whatever and looking right now, about how this will all play out. I can tell you that, for example, the testimony that we submitted on the issue of cutting off for the 450 is to say, look, you're going to impact 78% of the patients. Okay? And these aren't patients that are right now just seeing their doc that's in their zip code. Most patients travel outside their county to see a physician. So they've already got access issues. So, I'm not advocating either way, but at least letting them know that this is what's going to happen. And there are very few counties, in other words, there are very few legislatures who your constituents are not having to travel, having to see some of these physicians, as well as the fact that there was testimony that said some of the health systems don't necessarily allow recommendations by physicians or otherwise. So there are, we will, as the Oregon Health Authority and Public Health Division, continue to provide the statistics. We've done 2 reports out of, and you got the statistical, did you?
Yeah.
Okay. So yeah, you've gotten the things we're sharing with the legislature, we'll share back with you. We've got a report that's just coming out from the dispensary program about what's there, how many there are, how many have been licensed, in other words. So we're trying to give them a good framework of what this really looks like. Because I think, actually I've been super impressed with how thoughtful they all want to be about this. So I think if we give them good information, they will make good decisions.
Well, hey, thank you so much. That is the information.
Hello?
Yeah.
Hi there.
Hi, Brian.
Brian Michael here, raising his hand up high.
Hey, Brian.
Can I ask this fellow a question about one of the topics he just touched on?
Yes.
Hi, are you there?
Yes, go ahead.
Yes.
Okay, early on in your remarks just now, you mentioned that the legislature was concerned about the experience in Colorado. Just kind of curious, what concerns did you hear? Did you hear any favorable remarks, like, gee, look at Colorado, it's doing great, we ought to do the same thing? And do you know, like, who was concerned about Colorado, and who thought Colorado was a great experience? Can you address any of that?
So let me address it from what Colorado themselves said, because I've been there and was part of a conference there. Colorado...
Actually, actually, I'm more concerned with what Oregonians have said than I am with what Coloradoans have said. Thank you.
And I'm sorry, I will not address that, though. Okay? I can tell you what I have heard from Colorado and what concerns there are related to that, but I wouldn't want to speak for what I've heard from any particular legislator or otherwise.
Are they legislators in Colorado or the Department of Revenue in Colorado that you're affiliated with?
Public health, as well as the issues around the lawsuit against Colorado by the other states in terms of diversion, questions from Department of Justice, and there's the Cole memo, which describes how that works. So there are a number of concerns that that brings as well to Oregon. There is the concern about how long it was before Colorado was able to talk about how to appropriately use the products, as well as what the amount of THC in products, particularly edibles, and how they were labeled and marketed. So that's a really big. That's a lot of the discussion that's happening.
Can I make just use one bit of correction? Your statistics, very small note. It was very hard, in fact, possible to decipher how many actual patients, our participants in the Oregon Medical Marijuana Program, were 18 to 21. Because my guess is, if it happens this program, if you perform, that's going to be, those people will be prosecuted for the law without any incentive. So people that are children, people that are 18 to 21, you've got it from 20 to 26, I think the numbers are, and you've got from 18 to 20, but you really don't have any that are basically at birth to 21. Because those, from 0 to 21, from 0 to 21 is really the, 0 to 20, sorry, 0 to 20 is the focal point for those people will be very negatively affected if it happens to this program.
Well, just wondering, yeah, here it does have that patient rating, if you could modify that, so it's 1821 or 1820 to 21.
Thank you. I just realized I was 10 minutes over, so.
Yeah, you guys
thank
tired
you
of
so
hearing
much
from
for
me
your
yet?
time. No, thank you. No, it's been very valuable. Thank you so much for coming. That is greatly appreciated.
So, Ben, let me just, the one thing, just brief about the budget is that.
Actually, I was going to table the budget. I would love to talk about that.
I'm not going to talk to you, I'm just saying, because I heard her say how Chris Cruz had it, and there was different, we have different program support managers, you know, and that's why things change, because our program support manager now has his own tool that is that summary that I was providing, because that's what I had to work with for my program support. So he already has those tools set up. That graph he already has set up and says that I had to go and print the second page. Those things are established by that program support manager. Chris Greer was the program support manager. He had his own tools. So I can't say that I can tell him go make this like he made it, because he has set that up for all his programs that works best for him. And I go in there and put our grant number in and I print it out. But then when I did this, the last time I did it, I didn't get approval. There's an approval process that this officer has to approve what I shared, and I didn't understand that. So then the fiscal officer approved this budget to come out like this, and this is what I was able to share. So I will go, and Tracy we did send that other budget to the fiscal officer, and when she said no, don't share this. This is what has to happen. So I will try to go. Get the summary printed and see if she will allow me to share that. So the other thing, I hear you guys saying about all these projects. I've been trying to update you guys on these projects, and I did talk about our cars, but there's no new status. But I'll make sure in the meetings that I will continue to provide where we are with these big projects. And everything that we do, I always say, if the ACMM needs to review this. As a person comes out, many things happen, like ACMM needs to review this. So you guys do have, I do use you guys. So even like when we're making appointments, I say here, here's the applicants, let's give you a recommendation. So.
Well, I'm sorry. I hope you feel that you've been jumped down. Your throat been jumped down. And we apologize about that. It's frustrating.
Yeah,
it's frustrating for us too.
It's frustrating for me to hear that I'm not doing things when I do it all each time. I try to provide. So we provided this. Unfortunately, they put it in here this time. But Aaron went and printed it out. And this program, it hasn't changed. The only thing that changed was the C-Care, and it was another $1 million that was added to that. There was no new programs on here. So and this is biennial. This is what goes out to them biennial. And with
I hate to cut you off, but I'm not working.
That's fine. Go ahead.
I'm sorry about that.
That's
Yeah,
okay.
I apologize. We can go back. We have time at the end of the meeting.
Those 3 things.
Yeah. Thank you. We are now to officer elections on this.
Can we just one more thing on dialogue? I'm just wondering about the appointments. We heard that you're delaying the appointments until after the legislative session.
Yes, because yes.
Have the applicants been notified of this?
I have notified, when I send out a notification to you, to the ACMM first, then I send it out to every applicant.
Thank you. Okay, so.
Is that a yes? They've been notified?
Yes.
Yes.
Yes, I send it out to every applicant.
Are we doing that?
By email.
I would like to nominate Cheryl for chair.
Oh, okay, I second that nomination. All those in favor of nominating Cheryl for the chair of the ACMM? Oh, discussion others. Oh, yes. Yeah. Thank you. Can I get coaching on this? I need a little. I haven't done this before, so I will with the Sandy. You guys really well. So, I guess, are there any other people that would like to be nominated as well? And any discussion? Do we need discussion on that? Or discussion?
Are you ready?
Are you ready? Yes. We're switching off. Okay. So all those in favor of nominating Cheryl as the chair of the ACM, electing Cheryl as the chair of the ACMM. All those in favor, please say aye.
Aye.
Brian?
Brian, Laird?
Laird?
Laird said aye. Aye.
Aye, okay. Objections, abstentions, the motion, or the election passes unanimously. And then, are there any other, I guess, the vice chair? Would anybody like to nominate one for the vice chair for the, I will open it to the floor and see.
I move to nominate Ben as vice chair of the ACMM.
Second.
Discussion? Okay, all those in favor?
Aye.
Aye.
Aye. Aye.
Great. Objections, abstentions, none. I pass. Unanimously.
Ayes have it.
I have it, absolutely. You. Okay, great. As the vice chair. Any other, let's see, nomination subcommittees we've done? We don't need to renominate subcommittees or any of that. That's it, right? Okay. Great. Well, that was good. That made up for some time. And then subcommittee and other reports. I know we have Jerry. Are you?
Stepped out.
Oh, we stepped out. So what I'll do is I'll switch it to outreach, and Kelly if she's here.
Hi.
Hi. Oh, there you're right. Good job. Okay.
Oh,
Okay,
so my
ready,
outreach
ready to give your
report,
outreach report?
I'm deferring to Kelly.
Yeah.
Okay, let's pass some of these around.
So Kelly works for the Community Partner Program, and she had reported last time that she was going to be going around to the clinics to get them to help sign people up for the OHP, and she's going to report on where she is on that.
Okay, so my name is Kelly Page, and I am currently an outreach coordinator for the Community Partner Program. And I am working for the Oregon Health Authority. My main office is in Salem, but mostly I spend most of my time in Eastern Oregon, actually. But I convinced my manager last year that we should be doing outreach to the medical marijuana community, because my program works with a lot of underserved populations trying to help enroll people into healthcare. So with the expansion of the Oregon Health Plan, a lot more people were eligible for that program than before. And I noticed from your statistics that a lot more people were able to get a reduced fee than before, previous years. That's a great statistic. Oh, okay, page 8. Percentage of reduced fee eligibility trend by year. OHP went from 2.5% to 22.5% last year. And I bet there's a lot more people who don't even realize that they're eligible for the Oregon Health Plan and that they could get a reduced fee if they were on it. So what I did was I printed up a bunch of letters that were sort of different, like from this one, because it was about open enrollment, which ended February 15th. And I went to as many dispensaries as I could get to in December and January, and dropped off a bunch of these letters around, and actually spent a lot of time talking to the staff who worked in the dispensaries, most of whom didn't have health care themselves, and talking to them about enrolling in health care. I had some very interesting discussions about getting traditional health insurance. Some people were like, yeah, I really need that. Some people were like, no, all I need is cannabis. But had some very enlightening conversations. But we at the Oregon Health Authority think that everyone needs health insurance in addition to medicating with cannabis. And so we want everyone who has an Oregon medical marijuana card to also have health insurance. Plus, it's actually required that everyone in the country now have health insurance, or they have to, if they have enough money to file taxes, have health insurance. Plus, if you are eligible for the Oregon Health Plan, it's awesome health coverage for free. So we want everyone who can be on that program to be on that program. So I just did a new letter just yesterday, got my boss to approve it. You've heard the term open enrollment. That ended for most people February 15th. That's for people who are buying commercial insurance, private plans. Oregon Health Plan and Healthy Kids for Kids, that enrollment is available year-round. So I've got a new group of letters. I'm going to be, going around and trying to get those into dispensaries for the rest of the year till open enrollment starts again. Cheryl.
Kelly, I thought they were going to reopen the open enrollment because of, I don't know, people didn't know or...
Yeah, there are what's called special enrollment periods, and a lot of times there's special enrollment periods. Say if you move to Oregon, that entitles you to a special enrollment period. If you have a baby, that gives you a special enrollment period. This is for commercial plans. This year, if you lived under a rock for the last 2 years and didn't know that you were going to have to pay a penalty, if you paid a penalty this year and you're like, what's up with that? If you're going to go online and attest to all these things, you're going to be given a special enrollment period for this year, between March 15th and April 30th. So, if you're willing to attest to the fact that you had no clue that there was any sort of penalty, yes, there's a special enrollment period for special this year for commercial plans.
One of the really nice things about the OHP is right now they don't look at your assets, they only look at your income. So
yeah,
that's huge.
And of course, no insurance anymore looks at your health. They only they ask about your income. That was probably the best part of the Affordable Care Act. Insurance companies can no longer turn you away for pre-existing conditions. So they ask if you're pregnant and if you use tobacco, cannabis, and that's it. That's all they ask. So the other fabulous news I have to report here is, this community partner program. We partner with all sorts of agencies all over the state to enlist the help of certified application assisters to help us enroll people in healthcare, because there's 8 regional outreach coordinators. We can't do it all ourselves. So we have grantees, we have volunteer organizations, we partner with healthcare providers, with clinics and hospitals, with insurance agents, we have almost 250 organizations that we partner with. And we just added a new organization, which I'm sure is the first ever national cannabis-related community partner, and it is Mamas. Our very own Sandy Burbank is now, her organization is now a community partner with the Oregon Health Authority to help enroll people into healthcare. So I'm going to be,
Emily will be one of the people you'll be training. Way to go, Laura.
So we're going to train up her staff. I think we have 2 in Portland, 2 in the Dalles, and 1 in Bend. And we're going to take pictures, and I'm going to send a letter to the President of the United States. I'm going to say, hey, I'm sure that this is the first in the country. So anyway, we're very pleased about that.
It's a pretty good incentive, Kelly, when I can say, hey, you can save $150 if you sign up for this insurance.
Exactly. So, so they can go to a mama's clinic. they can get help getting their medical marijuana card, and then they can turn right around and get help with getting enrolled in health insurance. So I think that'll be a really great thing. And so, you know, any other community clinics that you know of that would be interested in doing this, please give me a shout out, and I would be happy to train your staff as well and talk to you about maybe future grant opportunities that we're going to be hopefully offering in the spring. So that's what I have.
Thank you.
Okay.
Thank you. Do you, Gary, are you ready? Do you want to go back to you, or do you want to?
Sure.
Yep. Okay.
I think I'm going to change things dramatically. I don't even know if I'm going to use this. I mean, this was an enlightening discussion about the relationship with OMP and relationship with the authority. And so it's like, it's really helped me to see where we are in terms of making recommendations and the strength of this committee. I'm looking at these items about where monies are going to. Some of them are really good programs, things I've worked closely with in the past, and currently emergency medical services, I'm involved with drinking water programs, certainly involved with farmers markets and the trauma system. And so I can't disagree with some of these things. What I can really disagree with is how do we hold on to some of this money to do the good work that we really need to do, all of us, because we're all on the same page. Oregon Health Authority, OMP, ACMM, all on the same page of providing good quality health care with minimal side effects. And I think in order to do that, we really do need research. Research is money well spent. We have low-lying fruit, easy projects to pull off. I was just speaking with Steve about the public program. I mean, healthcare delivery in this state and in the country is really appalling. It's a broken system. We are 4.5% of the population in the United States are using 90+%, 99% of the Norco. I mean, the amount of narcotics used in this country, we are consuming 80% of the narcotics. Here we have an option that can help people get off of narcotics, that can reduce the narcotic dose if used synergistically. What we're doing right now is we're spending a great deal of money to help a few companies manufacture Norco this quarter. $4 billion. I mean, it's embarrassing how much money is being spent on narcotics and what? For crippling society, it's costing $78 billion annually just to repair the damages from narcotic use when we have some really good alternatives. We're not spending money. I don't see it here. I'm not sure if this group is to deliver or take it there, but I would like to ask for ACMM's support in making a requisition to OMP, that OMP makes a requisition to OHA to say, we really do need research to try to turn around a failing healthcare delivery system, of which this is just a small part, but a shining light in terms of potential. So I would ask for ACMM support in making this recommendation, because I think we need to find a way of having more influence on this budget than just to have the money swept away into programs that legislation decides that we need. And again, these are not bad programs, but I think we have an opportunity to really excel and to accomplish all of our shared goals of providing quality health care for people in Oregon. Oregon is one of the biggest offenders in the country. In 2011, there was more narcotics consumed per capita in Oregon than any other state. I mean, it's like really embarrassing statistics that can be turned around that medical marijuana has. In 2013, we were second under Oklahoma, and I heard something about Oklahoma yesterday in the news. Again, not very flattering, but still, it really puts things into perspective that Oregon really is not getting gold stars. And I like the idea of collaborating and working closer as a group, because I think we're going to need to work closer as a group. Oregon Health Authority, OMP, ACMM, if we're gonna try to achieve the kind of goals that we're all setting out to do. So anyway, I wrote a letter asking for support towards research from this budget before it slips away to fund other failing healthcare delivery system. And that's really it. I had a phone call with some pretty high-powered people, many from Oregon, who sit on the scientific advisory board. I think that's what we need. I think we need to bring in really smart people to try to problem solve. And so I would ask that this money that we earmark, $2 million a year, for research, and take that up towards the Oregon Health Authority and see what they say about that. So, thank you. Henry?
Do you have a, is this letter, yeah, the proposal here is to,
The first letter was really to ask for input from ACMM. I really want to thank those who did respond. The emails and phone calls I got helped me to shape this. I just wanted to reach out and make sure there was some sort of alignment here before I put out the second document on page 2, which is a proposal, which I will read for those who don't have it in front of them.
Is this in the form of a motion?
It is.
that's okay, so the motion is for
A motion, whereas the advisory committee on medical marijuana acknowledges the importance of medical and horticultural marijuana research. And whereas research in medical and horticultural marijuana might contribute to scientific knowledge, enhance public safety standards and practices, and the establishment of sound public policy, the proposal is that ACMM proposes this Oregon Medical Marijuana Program petitions the Oregon Health Authority to retain OMAP redistribution funds in the amount of $2 million per year over the course of the next 5 years and dedicate these monies to medical and horticultural marijuana research.
Second.
discussion.
Yeah. Now, is this, that's $10 million, is that going to go into a pool and then researchers would draw against that or send for grant money? Is that what the proposal is?
Well, what I'm conceptualizing is having an independent organization, a 501c3 public benefit entity, broker those funds with a scientific advisory board that looks at proposals that are coming in and awards funds in a very transparent manner, reporting back to Oregon Health Authority and to this board, the results, and hopefully applying those results to the population. Right now, if we did nothing more than a data mining operation, there's so much research coming in right now that needs to be tallied and needs to be meta-analysis is performed and needs to be used. If we just use the information coming in, we'd be way ahead of some of these huge problems that we're facing. So that is the proposal, is that we would broker these funds through a nonprofit in a transparent manner. Excuse me. And yes. Sure.
In light of what Steve said this morning, I'm wondering if we need to propose this to the governor instead, or in addition, just because he said the governor's budget exists and there's not much we can do about it. They have these secret discussions and decide what to do, but maybe we should just get the governor, the legislature, the Oregon Health Authority.
I contend that if it makes it to the Oregon Health Authority, it will work its way up.
Yeah.
It's a good place to start. And if it makes that far, we're on our way, because we somehow have to get it out of this committee.
Right.
And move it up the ladder.
But I'd just like to see it sent to all of these players, straight to them, as well as Oregon Health Authority. I mean,
Can we finish the vote on that?
Well, yeah.
Well,
And then do a motion
Yeah,
for
still
that?
well, it would be
Friendly
friendly amendment if we
Yeah.
get that, yeah.
But if there's more discussion.
I would like to see some education looking in there too, because I think the thing that's kind of concerned me from the beginning is we've got the OLCC that you can't buy a beer in this state without having in a public place without somebody having had to go through the liquor training. But on the whole medical marijuana, if there's no real, anything in place for training the folks who are actually dispensing it. I don't know if this would be the, if we're getting all this research, it would be great to have some, something linking it to education, because just a way to disseminate it.
Let me comment on that for a second, because this organization, Health Research Institute, one of its missions is education. Now, one of the scientific advisory board members is overseeing a university called OHA. Is anybody familiar with OHA? And their focus is education. They've really aligned with us because they're wanting more research so that they can disseminate information. So it's the board of Health Research Institute that's really insisting that education is a strong component. And I'm not saying that this money should all go here. I'm saying it should go somewhere, and I'm going to leave that out of this proposal. I think it should go into a 501c3 tax exempt public benefit organization.
Yeah, sure. Just a couple friendly amendments, maybe one to address what Cheryl said. Maybe friendly amendments such as petitions the Oregon Health Authority. Should we ask the Oregon Health Authority to work with the governor's office or us directly with the governor's office? Is there any way to? Okay. So friendly amendment to petition the Oregon Health Authority to
petition the legislation.
To petition the legislature and the governor's office to have a budget approved for everything else you wrote here. And the second friendly amendment, the second whereas, also add to, let's see, Hence Public Safety Standards practices, and savings of state expenditures for prescription and medical treatment. Maybe better way to word that, but just want to add a cost savings aspect to the whereas, to our basis for asking for this. So I could see this.
And improved sales pitch is what you're talking about?
Yeah.
Don't just say more that the cost savings that would be directly attributed.
Did you get all that?
I think I can get it.
I like that, but again, I have concerns that us petitioning the Oregon Health, the OMMP, to the Oregon Health Authority, to the legislature, is it going to happen if we don't petition them ourselves as well?
I think if we approve this, we can put this letter wherever we
Okay.
want. I really do.
Yeah.
And if we take our baby steps,
Yeah.
and they kind of are. Listening to this dialogue that just transpired, I see that we have some baby steps to make to really gain some credibility.
I just don't want to stop at OMMP and then not going where,
Well, and I think there is an authority for the chair that they can authorize, either directly do it themselves or authorize on your behalf for Jerry to go speak to the legislature and to the governor directly. And then with that authorization with the board, we can offer it. That can be a direct authorization, my understanding. So you can actually have a direct conversation.
We had a telephone conference, about 9 or 10 of these people here, and they're very motivated people who are committed to health excellence. And I don't think any of them are going to stop short of really trying to get this to where it needs to go, to really turn around some public policy in the state. And so I commend them.
Sorry.
Well, I was out of the room for a second. I just want to be sure. So we're asking for this money, but we're not assigning it to any particular group to administrate. That would be determined. Or are we asking it to go to the Health Research Institute?
Yeah, are you asking for it to go to the Health Research Institute or?
And you get the money to decide what's.
I don't know. I leave that to this group to decide. It is one entity that I have a lot of confidence in, and I've been around for 23 years. And so But I think we just need to find a way to devote research because it's going to provide the kind of solutions or answers to a lot of the questions we're all raising about healthcare delivery in this state. So,
Oh, sorry. Oh, sorry.
Okay, I just want to be sure about that, so we're just asking for the money right now, okay? And then the second part of my question is, we throw the word education around a lot, but the OLCC has been very remiss in educating users about safety with alcohol. Mama won an award in 1992 for our book, Using Alcohol Responsibly, and the reason we won the award because of our long-term ongoing efforts to reduce alcohol misuse and abuse. The head of the drugs and alcohol, Jeffrey Kushner, had a fit because of it, because of our position on the marijuana laws, and they kind of just blew us off. They never did anything with our book, or never did any education of the patients. And I think we need to be careful. We're educating a lot of people. I don't hear any talk about educating the patients, which is what we do at our clinic. The patients come in the marijuana clinics, I mean, yeah, maybe some are coming to get high, but most of them that I'm dealing with are people, they don't know anything about the medicine. They're out of desperation. They've tried all the other stuff, and they are seeking help. But they don't know where to go with it, and that's one of the main things we do is there's different forms. They operate differently. And I want to see, we're talking about education. I want to be sure that education is going to the patients, not just the people who are selling stuff to the patients. And with the history of the OLCC and their lack of education, I really think that we need to really hammer home that the patients need to be educated. And I'm not sure how it's going to come out of all this, but I'm just need to keep that in mind. The patients are the ones who need to know.
I would recommend that we insert the first whereas. The Advisory Committee on Medical Marijuana acknowledges the importance of medical and horticultural marijuana research and education.
Yeah, perfect.
I also, I don't want to put down OLCC because it seems they're hot on the research trail. And it's a little embarrassing for me that OLCC is really moving in that direction, and this entity is not. And I applaud them for incorporating that into their proposed budgets. But I think it really should be incorporated into our budget. I don't like money being shipped down when it has benefits. I didn't mean to interrupt.
No, I just want, I'm curious about training.
Yeah, just one second.
Jerry, on Senate Bill 480, how does yours dovetail, or is it independent of? It says establishes a semi-independent state agency, clinical research and campus board. So they wanted this bill is to actually a research board, and then it goes on to say directs boards to promote use of cannabis as treatment for medical conditions, compile information on medical use of cannabis, and identify the support organizations and entities that engage in clinical research. So I can see where, if we could put together something within us and dovetail with that, it's getting in harmony with that, it's more likely to go somewhere than if we're at cross purposes. And I don't know quite how to do that, just other than we'd be aware of that the state has this Senate bill. I don't even know whether that's been passed or whether that's...
Yeah, I think talking to the person who's the legislator that submitted it was very good.
Yeah.
Who was that?
Edwards.
This is Edwards. Yeah, this is Edwards' bill.
Well, I think it's a feather in our cap that we can keep pace with that. And we can define the same sort of goals and priorities of this group.
Yeah.
Without dealing with those. And they can move it right up towards the legislation.
And then one other just comment, and it's not, so it's not directly, but just say that the people that are on your list there, a strong request is to request them. After this vote and everything, to request them to directly speak to every person, including yourself, directly call the governor's office and call and have a direct conversation and actually go down the scale. Because by far the most effective, we can present letters and put them, but it's really the delivery that's valuable. And the more people that deliver it, that have those street cred right there, the better the chances of success. And so if those guys want to get in that game, then that would, and it sounds like they are motivated, that would be a way if they're willing to take that kind of role. valuable, and I'm sure they would.
It says that, that Senate bill was referred to 91 committee and then Ways and Means, but there have been no meetings on it so far. Yeah.
Be on, yeah. So,
Anyway, the timing's good.
Yeah.
No meetings, let's initiate this as what I would recommend this group.
okay. Any other friendly amendments that people would like to make to this? Okay, I move to put this to a vote.
Do you want to read it?
You want to read it more? Actually, no. We're gonna do like no.
I cannot read that whole thing, but I.
So Jerry, would you like to read with your understanding of the two friendly amendments that we spoke of? The one with, oh, you do have it?
I
Okay.
can.
Okay, thank you.
Whereas the advisory committee on medical marijuana, ACMM, acknowledges the importance of medical and horticultural marijuana research and education, and whereas research in medical and horticultural marijuana might contribute to scientific knowledge, enhance public safety standards and practices, healthcare cost savings, and the establishment of sound public policy, ACMM proposes that the OMP petition the Oregon Health Authority to retain OMP pre-distribution funds in the amount of $2 million per year over the course of the next 5 years and dedicate this money to medical and horticultural marijuana research.
And education.
And education.
All those in favor?
Aye.
Objections?
Aye.
So no objections, any abstentions? Okay, the motion passes unanimously.
So who is doing this?
So now let's go to the round two is that the moving this forward, right? So one, this is the, now I think on the OMP side, the directions are clear. Now on your side, is this something you are able to spearhead and move forward with? And then authorizations, you can directly at this point, after this meeting, directly authorize any activities.
So we can work together and work all
directly.
the
Can you guys do that, work directly in
Yeah,
communication?
I think the next steps is just what you said. I think OMP has a directive now to Oregon Authority. I think that's a huge step forward.
And but I guess what I would want you to hear and both of you hear is that I think relying on that solely would be less, I'm just saying being very proactive at this time would be very beneficial in the success of it.
Even a press release.
Yeah, exactly.
That'd be great.
To say that ACMM has endorsed this.
A question, how many of your group are local? I mean, local instances of Oregon that really could go down to Salem?
Anthony Smith is local. Anthony Smith has a laboratory. Keitha Jensen, 4 years, she directed cancer research at Yale, she's now local.
The reason I ask is it'd be better if you had a mass.
Eric
Yeah.
Garcia is local,
That's
Marvin Hossman is local.
So
Christian Lee is local.
and I think our statement, like you're saying, is doing that. It's really just, it's not just you having the conversation. The more people to have that conversation in unison is really what we found to be very effective. Any other? Or
Just so Jerry, then would you be willing to communicate with Senator Edwards or the Measure 91 committee?
Yes.
Okay, great.
Happy to jump on.
Okay, and anything I can do, contact me. I'll help you.
Thank you so much for putting that together. It's great. So next we have Todd and this dispensary program report.
We're setting up the PowerPoint, which we would have used if we didn't have it. That helped me to read it.
Okay, and then if you'll look on the right-hand side at the bottom, there's the Todd's report. Take your order.
Well, there's no activity in the dispensary program committee, so I don't have a report to submit on that, but I need to the next one.
Yeah.
Okay. So, as everyone probably is aware of, the 2015 legislative session has been underway for over a month now, and it's clearly the busiest legislative session for cannabis that we may ever see. I hope so. And of course, there are proposals from every side of the spectrum. But generally, bills that are related to the OMMP or medical marijuana are generally assigned to the House and Senate Healthcare Committees. Any bills relating to Measure 91 or adult use cannabis is assigned to the Joint Committee on the Implementation of Measure 91, which I affectionately am calling the Joint Committee, to reduce the mouthful. And anything relating to industrial hemp is being assigned to the House and Senate Agriculture and Natural Resources Committees. And of course, all these bills may have subsequent referrals to Ways and Means and Judiciary and other relevant committees. So I'm going to report on the Joint Committee and the Hemp, Natural Resources and Agriculture bills, and Cheryl is going to report on the healthcare bills. And I would, after I'm done, would ask the chair to recognize Anthony Taylor because he's been on the ground in the Capitol probably more than anybody, so he can report on what's going on the ground. But as you can see, my handout has all of the 21 bills that are currently assigned to the Measure 91, the Joint Committee. There were 21 as of yesterday. There may be more. But anyway, the Joint Committee holds public meetings regularly every Monday and Wednesday at from 5 to 7 p.m. at the State Capitol here in Room B. There are public hearings, and so anyone can attend. Not all of them have public input or public hearing portions of it, but you can witness their business. Mostly what they've been doing so far is informational hearings. They've been, which is almost all invited testimony. They've just had one meeting so far to have a public hearing on 3 bills, but it's just been largely informational ever since. I have a list of all the topics on this handout that they've gone over already. One of the informational hearings was on the subject of the Oregon medical marijuana system. And I was really disappointed to find that nobody was invited to represent the ACMM. And as far as I know, nobody from the OHA or the OMMP was invited as well. Is that correct? Because there was nobody that presented. Was anybody from the OMMP or the Oregon Health Authority invited to the public to the testimony on the Oregon medical marijuana system?
Police even.
Right. Well, but he didn't testify.
No, he was.
No. Okay.
Hello.
And yes.
This is where I was invited to testify. I was able to testify in person, but I sent written testimony, and it was passed around by staff, and Representative Wilson made kind remarks about me and my input, and so there's that. I was not invited necessarily as an ACMM member, but there we are.
Yeah. Okay. Thank you, Laird, and thanks for submitting that written testimony. Fortunately, Anthony Taylor presented most of our priorities that we established at the winter 2014 meeting. So at least the things that we had come up with as far as priorities were represented. But it's very disappointing that they didn't seem to have an interest in hearing from the ACMM or the medical marijuana program, which was the topic of their discussion. So therefore, I strongly encourage the officers of the ACMM as well as the Oregon Health Authority to get in there and educate the Measure 91 Joint Committee on what this program is about, because the climate is indicating that this program may be on the chopping block, or it may be folded into the OLCC, or we don't know. But the OLCC really needs to understand this program, even though as of now they're not they don't have any charge to implement it. But most everything that the OLCC is going to do with the adult use program has implications to medical marijuana patients and the delivery of medical care and access to medicine. Whether it's on the face or not, it's very strong implications to this program and the patients we serve. So anyway, there's the list of all the 21 bills and their summaries. The legislature has improved their website in the last couple of years, so it's a lot easier to follow the committees and follow the bills. And so I encourage you all to get those e-updates, the e-subscriptions from the legislature, so you can keep current on the Joint Committee and all these bills. On hemp, there are currently 2 bills assigned to one to the Senate Agriculture Committee and the other to the House Committee. Senate Bill 881 fixes a flaw in the 2009 hemp bill, which originally didn't allow production of hemp seed for anything other than planting next year's crop. So that's going to fix that if it gets passed. And Buckley's bill repeals the requirements for hemp growers to be licensed by the Department of Agriculture. Some bills that are expected to be introduced include amendments to the Industrial Hemp Act to establish control areas to prevent pollen contamination between hemp and marijuana crops. That bill hasn't been introduced yet, but it's expected to. And also the quality assurance bill that I reported on previously, that I've been working with Representative Buckley's office on. And also last night, or tonight, the OLCC is the invited testimony for the Joint Committee, and they're going to be delivering their recommendations for legislative changes to implement Measure 91. And so I included the links here to the OLCC already reported the recommendations, so you can read those and submit comments to the Joint Committee on how you feel those recommendations will impact patients in the program. But I also listed some of the most relevant OLCC recommendations that affect medical cannabis. And you can look those over. Those include how and if we go about co-locating medical dispensaries and adult use dispensaries, and other aspects of possible integration of medical marijuana in adult use. But one, they also want to adopt our definition of immature plant, which we've been trying to change for years and years because it makes absolutely no horticultural sense. The Measure 91 definition was a little bit better, that it didn't, have the 12-inch rule, but anyway. Also there has been a federal bill that was just announced yesterday on Chris Conrad's birthday. So happy birthday, Chris Conrad! It's actually a pretty decent looking federal bill. Rand Paul, Cory Booker, and Representative Gillibrand, they all consulted with the Marijuana Policy Project and Americans for Safe Access. And basically the federal bill would reschedule marijuana to Schedule 2. It'll allow limited interstate commerce for low THC and high CBD medicines, ease banking restrictions, reform NIDA to broaden access to cannabis for medical research. and allow VA doctors in medical states to recommend cannabis for certain conditions. So it's probably about the best federal bill that I've ever seen introduced. Usually they are often lacking because they don't expect them to ever get passed. So this actually may have a chance at heck to get passed. So contact your federal representatives. That's all I have on legislative.
Did you say there was a meeting today?
The Joint Committee regular meeting tonight at 5 here in the Capitol. And it's an information session for the OLCC to present their recommendations. So no public testimony today. Tonight.
Tom, none of these bills are referring to training of people in this industry. And we talked earlier about education, especially those that are dispensing to patients or even adult consumers. Do you, based on your experience in the session, do you see that coming?
Well, there are some in here.
Okay.
They're just not really included in the summary because, for instance, I think most of Buckley's bills, including 2676 and also the quality assurance bill that will hopefully be introduced. Much of that comes from Rob Bovet in his desire to see medical marijuana handlers, anyone who handles marijuana in a dispensary or any licensed entity, to have their own registration, and that would also require some training as well.
And they're doing that for people that are liquor stores as well, too.
Well, right.
and it's likely that as Steve pointed out, the Joint Committee is probably just going to fold everything into one big omnibus, maybe one or two, but basically one big omnibus. So I'm pretty sure that the handlers part of it is going to be included.
And I hate to cut this, but we actually have from 1 to 2:15 is when we have the legislative proposal review and follow-up, and now it's lunch and it's 12:03. And so what I'd like to do is, Anthony, would you be available to come after lunch? Okay, great. And then what we'll do is we'll break for lunch now, and we'll all be back here at 1 o'clock sharp, if you could. Thank you so much. Thank you so much. And so, we are going to continue on with the legislative proposal review and follow-up. But first we're going to complete, I think, and start off that with any Q&A finish with Q&A for Todd and then go to Anthony. And so Todd was speaking about the legislative parts. Is there any questions you have for the lunch for Todd? Anybody have any questions for Todd? Nope. Okay, so then. Well, how lunch is? Then Anthony, you're on deck if you'd like to share with us legislative update.
All right, for the record, my name's Anthony Taylor. I'm one of the co-founders of Compassion Oregon along with Cheryl Smith, and I'm a legislative liaison also for that organization. Boy, this may be the worst legislative update y'all have ever heard. I can't answer any questions. I will say this. There are 42 bills right now introduced in the state dealing with marijuana, and there's probably another half a dozen or so that are going to come out. We're waiting on Todd's bill to come out. We're waiting on another version of 3400 from the Senate side, the Measure 91 committee, and whatever else might pop up. There hasn't been a lot of action, as Ted said. Sorry, Todd. As Todd said earlier, the Measure 91 committee has only had a public hearing on 3 bills, and they were basically courtesy hearings. And that means that they got a hearing because they were introduced, and so they have a hearing, they talk about it, and then they decide not to talk about it ever again. Now that may, the League of Oregon Cities and Associated Oregon Counties, that will probably pop back up again for further discussion as they proceed along the path to implement 91. What I find confounding about the Joint Committee on the Implementation of Measure 91 is the first thing they tackle is changing the Oregon medical marijuana program. I don't really quite understand it, especially since most of them have stood up and said that we need to protect this program. So part of that equation is that they're trying to make at least the tracking and reporting of the marijuana, the medicine that's being grown by the patient growers, to be part of the system that allows the OLCC's comfort level to be raised so that they can co-locate stores. And that's what we keep hearing down there is, without this tracking system that they're proposing for all medical marijuana growers, they're not going to co-locate, and I think that will make some people jump the fence and get their commercial license and not have a dispensary anymore, and that's going to, in the end, impact all our patients. And so what we're trying to do is set up a system that will allow the program not to change too much, but boy, there's just this train running full speed ahead that says if you're growing more than 12 plants and less than 48 plants, you're going to have to track it and report it to the OHA. Everything you do. Planted 26 plants or 36 plants on this day, 2 months later you pulled 4 of them because they were rotten, and then you harvested so many of the plants that were left, and if you created any medibles or concentrates or butter or anything like that during the course of a month, there'd be monthly tracking and all that sort of thing. Created a can of medibal or a concentrate or any of that, that all has to be recorded. And in the end, you have to record how much flour you had, how much leaf you had, things of that nature. They think it's going to prevent leakage, but if seed sale was going to prevent leakage, the Kansas and Nebraska wouldn't be so Colorado. And the other point that I always try and make is that you're trying to prevent leakage. What are you going to do in September and August when probably 100,000 Oregonians are going to be harvesting maybe 4 plants? That's 500,000 plants, 400,000 plants. So anyway, but it's raising their comfort level, and we'll see where it goes. Like Todd said, there's a number of bills that were referred to the Measure 91 committee, and some of the ones that are left have a subsequent referral to the 91 committee. The House Health Care Committee heard the House Bill 2630 last week in front of the chairman, because the House was in session and in the middle of the floor debate. But the chairman had the courtesy to come down and listen to the people that had shown up that had driven in other parts of the state. They're still digesting it. That bill, as we all know, is already part of the administrative rules for the medical marijuana program, and the purpose of this bill, as it was explained to me, was to implement a mechanism that the OHA could use to inspect clinic records, because they really don't have it. They say that you're supposed to allow yourself to be inspected, but they don't have the mechanism. And as Cheryl found out, Compassion Center, if they do any inspection, they subcontract it out. The other part of his reasoning was to have this conversation to make the world aware of why so few physicians were authorizing so many cards. And we ran the numbers the other day and discovered that if every doctor was writing only for 450 patients, that we would have to add over 100 doctors to handle the workload. And without participation in mainstream medicine, that's unlikely to happen.
Right now, there are 23 doctors that write
78% of all
yeah,
authorizations.
for one patient.
So
23 doctors each have more than 450 patients.
Prescribed 78%.
Yeah, well, not prescribed.
Or not prescribed.
And while that statistic may be shocking, it doesn't fully address the situation where mainstream physicians either won't or aren't allowed, because of clinic policy or group policy, to write authorizations. Now, some of those groups allow a patient to have a medical marijuana card. They won't kick you out of a pain management program as long as you have a card. And also with the VA, they won't kick you out of the VA or impact your VA benefits if you have a card. That's a really big reason why this program really needs to remain strong and get stronger if we can do it. And I've encouraged folks to take a look at VA policy in bringing the Oregon healthcare community along so that they're confident in recommending their patients to inquire about cannabis to the clinics so that the clinic experts can help them understand use of cannabis, how to use it legally, and all of that sort of stuff. And in the end, we hope that the OHP will begin to pick up, at least for the portion of our low-income patients that are already part of OHP, they'll begin, as the clinics are better established as these reference points for mainstream physicians, will be able to absorb the cost of clinic visits and associated fee costs. So that's our hope. We're working actually with Representative Lively to develop this better so that that 450 patient bill kind of goes away and we have more of a clinic oversight bill that really doesn't add anything that these clinics aren't really doing. It just legitimizes it and let them begin to be standalone clinics. Compassionate Oregon has through Representative Buckley's office introduced House Bill 2821, which is what we're calling a patient's rights bill, or some of us would like to see it be called the Jim Gregg or the Jim Carr Memorial Bill.
Yes, we would.
And in fact, Representative Buckley's office yesterday got in touch with me about adding some language for transplant patients. And we have submitted the language in California Assembly Bill 258, I think it is, that says just because somebody uses cannabis or has a medical marijuana card, you can't be discriminated against on any transplant list. Part of the language that's in our House bill is that it prohibits physicians from refusing or being required by another to refuse to dispense or prescribe medication to patients on the basis that patients engage in medical use of marijuana in accordance with the Act. So we want to try and bring that policy to an end. We're going to need a lot of help, I think, from the committee, both individually and as a whole. And as Dr. Lehrberger indicated, this letter from the ACMM encouraging the research aspect of medical marijuana. We need something like that for the patient's rights bill, and also something against House Bill 2781, I believe it is, which is a bill that probably won't get anywhere, but it's the kind of thing that can get legs. It's the bill that codifies what the Early Learning Council did last month when they adopted the rules that said medical marijuana patients, card holders cannot be daycare providers, licensed daycare providers. It's horrible.
They can smoke recreational marijuana, but.
Yeah. As of July 1st, they can consume all marijuana they want to after hours, and they can possess on site as long as it's under lock and key, be allowed limits on possession. But if you have a medical marijuana card, you can't be a provider. So what I've encouraged other people to do is step up and provide some funding to take this issue to court, because as evidenced by 2781, they're really intent on making sure this stays part of Oregon law. And 2781 prohibits the Office of Child Care from certifying, registering, recording, or providing state funds to child care facilities when a person with regular presence at the facility possesses medical marijuana card. You don't even have to use it. You're a caregiver that doesn't use cannabis but provides help with your partner or another loved one. You can't be a daycare provider because you have a card. So this, I think, is a really important one. It's a slippery slope. It's already been started. If one authorizing agency can prohibit licenses from being issued to cardholders, certainly another one. And ELC is under the Department of Ed, so how long will it be before the Department of Ed says if you want to renew your teaching certificate, you can't have a card? So the kind of issues that we're interested in staying on top of. The other thing, one other bill that we have introduced is one to allow DUI diversion people to be able to continue the use of their medical marijuana while on diversion. This is kind of tricky because it says, oh, you got busted for DUI and you still want to smoke pot. Well, that's the kind of attitude we keep hearing down there, is they're not making this distinction between medical and non-medical. And you see it in this kind of regulation, you see it in discussions with medical, you see it throughout all these conversations. And I think we really have to be vigilant about that sort of thing. So one thing I will say is things are moving at lightning speed down there, even though no action has been taken. We've been trying to get a hearing scheduled, and in fact, we're told that 2821 was going to have a hearing with House Bill 2636, but it didn't, because they're not sure if the program is going to survive the session, even though Measure 91 committee had indicated that that's what they're going to do. So
What's what they're going to do?
Keep the program separate from recreation. But there's lots of mixed signals down there. There's some people talking about how the new program will look, and there's other people talking about let's not change anything. So probably before the end of the month, we're going to get some definition on some of those lines, brighter or blurred or whatever it might be, but then we can move forward. There's some of these bills, like everything within a mile has to be prohibited, that, you got a public hearing, but that's one of those that won't go anywhere. One of the factors in the equation of co-locating dispensaries is that they don't do that. There's very few places, like in McMinnville, they have one dispensary, and most of the other real estate is already, all the renters and owners have said, no, we don't want marijuana in our building, so it's tightening up in that respect. I don't know how it's all going to end up, but I'm going to tell you, I'm going to be down there fighting as hard as I can to protect the 70,000 Oregonians that are already part of this program, and to also provide protection and guidance and education and resources for the general public out there, that now that marijuana is legal in January, have heard all these anecdotal stories about how cannabis helps this and cannabis helps that, and they begin to use it, and they begin to have their conversations with their physicians. And we want to make sure that even though they don't have a card, there's some protection for them. So it would entertain any questions.
I'm wondering if you or Tawana has any insight on that bill to eliminate, a whole list of advisory committees, including the ACMM.
I just scrolled through the word marijuana in there once, and I don't. We haven't analyzed it. I didn't know if it was just a house cleaning bill or if they make every program re-evaluate the advisory committee and reaffirm it. But we did notice that.
And they did list about 100 different, so it's not focused on this program, it's just like all of them, do we need this? Probably just driven the canal. Yes.
The other thing I'd like to point out, talk about a little bit, is the research aspect of all this. For as many years as I've been involved in the program, all the participants have said at this table and off and outside of that is this discussion about locking up the money, the excess money for research. I mean, if you're going to double our fees and you're going to fund other programs, the least you can do is take some of that excess and lock it up for research. But people can apply through a grant program to have access to this money to conduct some legitimate research, criteria to be determined.
Education too.
Education also. So right now, Senator Edwards has 2 bills in the pipeline right now, Senate Bill 479 and Senate Bill 480, which deal with that. Senate Bill 479 creates a task force on clinical research of cannabis and directs the task force to study and report on development of medical cannabis industry that provides patients with medical products that meet their needs. Report to be submitted by September 15th, 2016. The other one, Senate Bill 480, establishes as a semi-independent state agency the clinical research of cannabis board. So it's kind of like a wine board. They're kind of a semi-autonomous board that is filled with members of the industry, and they talk about all their issues, and they formulate opinions and suggestions to the legislature. My word on it yesterday was that the office of Senator Edwards is going to push forward on Senate Bill 479, which would create a task force. There's some fights going on over this research stuff. The OLCC wants control of it, and that's kind of makes me a little bit nervous. But if we could somehow get Senate Bill 480 to the top of the list to be discussed, I think that's the direction we would like to go, or we should go, because it's autonomous. The OLCC can't, or the OHA, for instance, or the Department of Ag doesn't have exclusive authority over the research. It's vested in a semi-independent board. That's what we really need, so that, you know, if somebody, for instance, if it was an OLCC, somebody that wanted to do research on hemp might not get as much traction as somebody that wants to do research on the industrial applications of cannabis oil in the medical industry or something like that. So that's what I'd like our community to work toward. I think, again, that's really about it. The bills that talk about 1,000-foot limits and things like that, probably not much will come of that, because all the implementation of House Bill 3460 from 2013 really deals with 1,000-foot, and actually has some pretty expansive definitions. So that's about it. I just I can't emphasize enough how much help we're going to need in Salem. We got on House Bill 2821. We already got the support of Americans for Safe Access. They support the bill, and they'll be helping us where they can, probably in legislative action alerts and things of that nature. But I was meeting with representatives yesterday to try and get some movement on patients' rights bill. So we can at least have a hearing. They haven't decided if they want to have it in the healthcare or if they want to kick it over to Measure 91. Right now, that's kind of what they're thinking about, kicking it into Measure 91. I think both committees would give it a fair hearing. And I think if we can get a hearing here before the end of the month, I think we'll be a long ways towards making some changes. Just let me back up here for a second. On 2821, we also we're asking that they create an emergency no-cost hospice card for patients who have been diagnosed with a terminal disease, to be able to get a card with no cost, and under emergency conditions, the physician will just submit the paperwork, and hopefully the program will submit the card, or issue the card. The other thing we want to try and do in this bill is protect the physician or the medical community in administering cannabis. Right now, they're allowed to do that in the licensed medical facilities. We want to extend that protection to outside licensed medical facilities for home hospice care people and palliative care people. We also put in their language that will create a lifetime card for lifetime conditions. So if you are actually going to be diagnosed with MS, you're going to die from that. You pay for your card once, and you don't have to go through that renewal process or pay any more money. It doesn't mean that the doctor isn't still going to be required to submit paperwork to the program. But you'll only have to pay for it once. That doesn't mean that if you have severe pain, you're not necessarily going to die from that, so it can't really be considered a terminal thing. I mean, it may haunt you until your last days, but you'll probably die from pneumonia or something else like that. And so there will be some parameters. The other thing that we're trying to do is expand the definition of the debilitating medical condition. There's talk of adding, in this bill, they add ALS, autism, and sleep disorders. We've been kind of rethinking that a little bit. The important thing that we're trying to do is say, reestablish the relationship between the patient and the doctor. And say if those two people decide that cannabis can mitigate your sleeplessness due to the narcotics you're taking for your pain management, that you can do it. And it doesn't necessarily have to be on the list. That's going to be a tricky one, but if we can get that, that really, it will help a lot of patients. So,
Does that have a number? Or is that one?
yeah, House Bill 2821.
Anthony?
Yes.
Somewhere in 2821, it seems to me I read a section saying that regarding hospice cards, that the program will respond electronically. And it seems to me that would be a pretty good way to speed that up. Is that still in that bill, Julian?
It is still in that bill. Some of it will be sorted out in rules, but the doctor just submits a piece of paperwork. When you're in that kind of condition, you're signing a lot of paperwork. You know, the ability to share HIPAA information, the authority to treat, the authority to issue a medical marijuana card, and that will just go electronically to the program. The program has 7 days to issue the card, and you're off and running.
All right, thanks.
Okay. So Laird actually was responsible for, pulling the language together to keep the physicians from refusing to, authorize use of cannabis concurrently with other medications. And again, as I said, we want to try and add the transplant language to it also. So.
Anthony?
Yes, sir.
One more thing here. My doctor put me on this pain contract, which has spurred this whole thing, and he said that, I said, so why were you required to do this? And he said, well, what they told me was that the state of Oregon required this. And I said, did you believe that? He said, no, not at all. And the reality is that the state of Oregon does not require any of this pain contract stuff that denies opioids to people using medical marijuana. The second part is, when this comes up for a hearing, one of the piece of information that the committee's got to have before it is a recent AMA study that said medical marijuana states had 27% opioid medicine overdose deaths than those who did not. So if they're putting people on pain contracts saying they can't use cannabis just because they're using opioids, they're setting it up for a continuation of a rise of the number of opioid deaths. And, it's happening all on the side of corporate medicine. Providence Medical Center, they were the last one that I've heard of to jump on that wagon. It just happened to be mine, and it did happen to me, so it pissed me off enough to do this. But we do have to let them know it is a real life or death matter for those people in Oregon who are not going to commit suicide because of overdose of opioids because they can't mitigate their symptoms with anything else, even though it doesn't work for all their symptoms.
That's a very good point. And one thing that's really interesting is Kaiser in Hawaii, which is like Blue Cross of Oregon, doesn't have a problem with concurrent use, and they allow their patients and their doctors to deal with medical marijuana all the time. But in Oregon, Kaiser has got us at arm's length. So all these kind of little factoids and everything, pieces of information that we can get to the committee will be helpful. The other thing about getting stuff to the committee, it's time right now for all of us to start writing to our legislators, Measure 91 committee, your own legislators, tell them we have to protect this program and here's why. And it's not too soon to start. We need to start immediately and make sure that they hear from as many patients as possible to protect this program as, and to strengthen it. So it's time to step up and start letting them all know that we're not going to sit still for it. And that, not only do we need to strengthen the program, but we need the OHA to advocate for the program, just like they do for, whatever, pediatric physicians or drinking water or anything like that. But we've been pushed to the side for so long, so often, that now they think that it's going to be an easy lift to dismantle the program. And we got to make sure that they understand it's not going to be an easy lift. So that's a personal feeling, but I think it's important that as many people can step up and speak in defense of the program. Well, thank you.
I just want to thank Anthony for beating the halls down there, walking the halls, paying for your parking, and encourage everybody here who has, if you can't go down, send some money.
And I would like to mirror that with everybody here. I'm certain that everybody in this audience knows more than one other patient. In fact, some of these have hundreds of patients they see over the course of a month. Some have thousands. And my request is anybody who knows someone who has an Oregon medical marijuana card, as a patient, as a grower, as a caregiver, talk to them. Have them call their legislature. Have them call the governor's office. Have them go down. Have them send letters. Have them do anything. Be unstoppable. Don't just kindly ask. Give them your cell phone number with the phone. Hand it to and have them call. You guys, a lot of you guys are in direct contact on a daily basis. And I appeal to every one of you that if you like and love the Oregon Medical Marijuana Program and believe that it helps thousands of Oregonians like I do, and like everybody here does, please, please, please take action, not complaints. Because I can be the first to do that. But please take action. Okay? And sorry.
It could even be as simple as a sign-up sheet where you have one letter and then everybody comes in and signs it, and that's what you send in. That's something.
Yeah, the thing is just play big. Think, get creative. Think of how you guys make a difference. If you're a grower here, my wife and I went to one of the listening sessions, and I talked directly afterwards to the chairperson of LCC. First things out of their mouth was that basically they don't have any, they have their way, they would have to get rid of the medical marijuana program, but there's no will in the legislature for that, but he's working on that. And the second thing was he thought that 75% of all medicine was by growers was getting diverted. And I said, wow, I've never heard that number. And I said, how'd you come by it? Well, he said, well, I'm a district attorney, and my friends. I said, oh, those friends you prosecuted? And he goes, yes. And so you need to understand that there is a lot of interest in the Oregon Medical Marijuana Program, at minimum, being directly controlled by the OLCC, specifically the cultivation. And so don't be fooled and think that everything will be okay with legalizations here and it won't be a problem anymore. And so please know and understand. I'll take those beans. But just at the end of it will be done. Yeah, but that's just my just to understand there's a lot, to mirror all this, there's a lot of interest in this not being here. So please, this is the time. If there's any time involved, this is it. And so to that end, we have a little less than an hour to go over the legislative proposal review and follow-up, to go over, so we started going over some of those reviews. What I wanted to find out was from the last action items, we had the list of items that we highlighted the top agenda items for us to address. We were going to be crafting and sending a letter out. And I didn't know, we requested that the OMP, I think if I'm not mistaken, draft that letter and send that out by our intent by motion. Or no, we were supposed to do it?
Yeah, but we're also supposed to get a list of things.
Oh, that list. Yes, we need that list that has the list of the items that we wrote down.
From my understanding of the action item, it was Cheryl was going to refine the language of the list. I did include the information in the meeting minutes, and as we discussed earlier today, I will create a separate document based on the pictures that are in.
Okay, great. And is that something you're still able to follow up on?
Yeah.
Yes. Okay, great. Okay, cool. Are there any other, in fact, so this is, I'm opening this up for everyone here at the ACMM to think about what action steps, similar to Jerry's letter, what other action steps we can take, sending letters, making requests, making, we already have a very important one going out. Are there any other things we would like to or want to address now that we know the directions that it's sort of heading and we don't have an idea? Are there any other letters we can send, people we can contact?
What is our relationship with the Oregon Medical Association?
If there is one.
Why not?
I don't know. I know that the nursing, what's it called, Oregon, the ONA, yeah.
They're very close.
They're very close, vehemently so. And so, but I don't know about the
In the past, it's kind of depended on who was in charge. And when Rick Bayer was involved and Rick was with there were times they've been friendly or just not involved. But I don't know, I haven't heard anything coming from them negatively at this point. Anybody else?
Art, have you had any experience
Well,
with the OMA?
Here's the thing, I think with it, that's gonna be an issue, because the OMA's malpractice program is good through CNA. And CNA does not like to insure docs who are giving cards. And so there's
The doctor's not giving the cards though.
No, we need
OMP
it. I know
is,
exactly,
but-
the point is, those who are giving the, I'll get my.
Writing recommendations.
Yeah, so that's the one thing that, whereas the other malpractice carriers don't have problems with it, as long as it's just marginal to their practice. So I would think that,
There'll be obviously, yeah.
but again, that's the insurers on one side, which is a national company, and we've got the OMA on the other, so.
So I'm sorry.
Go ahead, no, but
So the insurers for malpractice insurance, they have a relationship with the OMA as a group, as like a group pooled insurance thing. So they're insuring the doctor's malpractice, but they're not really insuring the policies or physicians. The
OMA sponsors that program, and it's the endorsed program, and then they insure probably half the docs in the state. So I would suspect that these thousands of odd docs, a good portion of them are probably with CNA, and they're unaware, CNA is unaware of their activities. So it's not to say there wouldn't be a claim, but it's a real area that's, because I'm talking with the underwriters for CNA. I represent a couple of the big companies, and CNA is a direct writer, but I'm talking with the underwriter. They're saying basically they're getting enlightened because the doctor's company, which is the biggest doctor-owned company in the country, and VetPro, which is the largest stock company, they don't have a problem.
Now, along those same lines, it's something Anthony and I have talked about through Compassionate Oregon, is starting to educate healthcare providers, i.e. start with hospice, in-home health, palliative care, some of those, and then just, come up with a program and start educating, and hopefully we can pull in some doctors. And I just think it's going to take a long time to get people on board, but I'd start with the actual direct care staff. Those are the people that spend most of the time with the patients. They don't have that malpractice hurdle.
Well, and to redirect a little bit, I guess probably right now is when I would say in the next, till April, between now and April, legislative session.
End of June.
End of June, yeah. So between now and the end of June, we have the opportunity most likely to sit by and hope that things work out or take action on the program. So what direct things can we do between now and June that will have the greatest impact is sort of what I was looking at the focus of this questions are. So and this opens it up to you guys too. What can we do collaboratively together to ensure the existence of the organization on our program as we have it today?
And our next meeting is June 30th.
Exactly. So this is it.
OMA, because, they do
represents so many different positions across the entire state.
Yeah.
And if we're gonna start at the bottom up, we should also start from the
Top
top down.
down.
It doesn't hurt to at least make the phone call and try to set up a meeting for the ACMM, maybe you too, and anybody else who would want to attend, to start that dialogue and see where they're at, and see where they're lacking in education and what we might be able to do to educate them. And we could get lucky, and they might support some of these bills for us in the legislature. I don't know if they would.
No, I like it. No,
but
thank you. So
it's an avenue.
Yeah, no. So the OMA and it's a
It's
Right.
worth trying, but my personal feeling is, futility with the MDOs, because when I was at Compassion Center, I had a board member who worked for a multi-physician office and really knew a lot of the doctors, and repeatedly we tried to get our foot in the door, and they wanted nothing to do with it. They don't want to be educated.
their financial existence won't hurt. They won't be able to be doctors if they don't have one. And so they don't pay the insurance, right? And so what I'm saying, even if they feel that way, right? Even if they feel for it, they're still not going to play with us because they lose their job if they play with us. And so that's or they can't.
They fear they're going to lose their job.
The reality of fear
is going to get them or something.
Or they've been told that they'll lose their right to prescribe pharmacopoeia, and and they do. And so that's the issue. They can't prescribe prescription drugs or opioids in any narcotics in any sense if they're prescribing patients cards and recommending.
We also have a federal bill, though, that was dropped too, which is, maybe a segue to open that dialogue.
For sure,
because
yeah.
if it's, because
But,
the gas is on a federal level, long shot.
And I'm not trying to shoot anything down. I think it's a great idea. What I was thinking is that we want to throw these ideas out and see which ones have the most forward momentum, and I think that's a great long-term play. But I think as long as the doctor feels they're going to lose their job by playing with us, we probably have a tough road to hoe to get them to even call the legislator. You know what I mean? And so, you see what I'm saying? Like, that's what I was thinking. I like that idea, and I want to run. Are there any other, I'm just putting those, because I got that down, talk to LMA. Do we have any other ideas more directly to get at it?
We have a lot of doctors who actually recommend patients to come to us, or who sign for patients and send them to us to be educated. And actually, I probably have a list of those people. I'm just wondering. They're just so afraid. Like when we offer to give an educational presentation to the doctors, nobody's going to come. They'll send their nurses in to talk to us one at a time, over and over again. One at a time, hospice, same thing, one at a time. They're also afraid. They're afraid of each other. They're afraid of the whole program.
Well, Sandy, bottom line is now that all these years have elapsed, they also don't know anything, and they know your doctors are the experts. They know that these doctors, you say things compassion.
Well, the doctors turn to us for education of the patients because they don't have, so they don't know how the program works, and they don't know about the medicine.
They don't want to add.
That's right.
Well, so back to it, are there any, and no, I thank you for that feedback. Are there any other items that we could say to take action on this?
One of our jobs is education, and this information represented today widely available in terms of the number of deaths caused by overdoses. It surpassed the number of deaths.
They can't hear you, Jerry.
It surpassed the deaths from motor vehicle collisions. This is huge stuff. I mean, what doctors are prescribing in their ignorance is killing people. There are side effects that are just outweighing the benefits. The costs of treatment of these side effects is outweighing the benefits. This is information that can be shared with them that, gee, you are prescribing a gun. There are options out there. Number one. Number two, there are a lot of doctors who don't prescribe narcotics or don't prescribe narcotics if a patient is taking medical marijuana. Is not contraindicated. In their mind, there's fear, there's concern, there's unknown, and there's air that put out a statement that these actually have complementary effects, that marijuana actually benefits and will reduce the requirements of narcotics. It is a fair statement.
That's great. So
Yeah.
I have a request on that.
One more point.
Okay.
In the where we prescribe 99% of the Vicodin in the world, Vicodin is made of a compound, 2 compounds synthesized that have no beneficial synergistic effect. Tylenol doesn't have a synergistic effect with narcotics. It's crazy how it's really dominated the market. It is for
I thought it was to keep people from overdosing because they'll get really sick.
But when you look at something that actually has a synergistic effect in narcotics, like medical marijuana, and actually reduces the requirement of narcotics, this is information that's good for doctors to have. That, wow, maybe these are safe drugs to work together, particularly with the anti-inflammatory effect of CBDs. So a letter to that effect might be really.
Would you be willing to craft, because you've already got all the stats, two things. One, the letter you're describing, but two, for the general public, a bulleted fact sheet that we could disseminate out to, once again, the individuals that were called. So they actually had facts. Did you know? Because a lot of people don't know these facts. Don't even know that more people die of, overdosing now in car accidents. Don't know that Oregon was #1 for that. Don't know any of what you just said. And so those are very powerful statements.
Physicians are the reason.
Exactly.
There is more overprescribing in this state than almost any other state. So we are out of control. So these physicians are just need to be better informed.
Okay, you go first.
Yeah, I think the bigger issue here is it has to do with Schedule 1.
Mm-hmm.
Let me just read this real quickly. And this is what the doctors are being told specifically up till about maybe a couple of years ago, that you mess with marijuana, we'll pull your card. We'll pull your right. Because they list Schedule 1, it's probably all of you guys know this, but I'd like to just bring it up. Defined as drugs with no currently accepted medical use and a high potential for abuse. Schedule 1 are the most dangerous drugs of all the drug schedules with potential severe psychological, physical dependence. Some examples are heroin, LSD, marijuana. Yeah, so as long as as long as they're dealing with that, and that implicit threat that they can get their basically prescriptive license pulled. It has nothing to do with
But wasn't that
malpractice.
before the Ninth Circuit case, Conant, that said the doctor can talk to patients about?
Again, saying until while it's Schedule 1, I think we're going to have a.
But in Oregon, it's Schedule 2.
Well, it's still federal. See, it's the federal that they're talking about. As long as it's federal.
No, we get that. It's really what actually is the case. Yeah, and that's not the key point. You really know the point.
If doctors prescribe narcotics and other medications for patients who are on marijuana, that's enough. We have great clinics set up for patients who want marijuana and visit. And so that program's already established. We just work again on 4 pieces and then we'll master it.
Todd.
Yeah, since we're tackling, all the policymakers, OLCC and the Joint Committee, et cetera, are considering various proposals of integration of medical and adult use or elimination of one, the whole dialogue, I think it would be helpful if we kind of came up with some basic parameters around that. So basically whatever it is they decide to do, I feel like we should, make it, clear that, that they're, that whatever scenario they propose, whatever system they propose, doesn't make it extremely difficult or impossible for medical marijuana dispensaries or the system of providing medicine to patients to be compromised. Because some of the proposals, many of the proposals, really threaten the ability of dispensaries, licensed dispensaries, to operate properly or to source material or to co-locate. So just the kind of the general consideration that the medical system needs to be protected, even though they're creating an adult use system that may not even mention the medical system, or if they integrate it, whatever. Another thing is preserving the lack of taxation for the purchase of medical marijuana. Even in the adult use system, if there's a way to legislatively, if someone presents their card that they don't have to pay the taxes. I mean, this could be an issue if the zoning and local government issues actually make it a lot more favorable for adult use dispensaries to locate and more difficult for medical dispensaries to locate. Geographically, some patients may, have only an adult use dispensary as an option. So I think coming up with kind of a list of some of those general parameters or considerations. And this is also why it's just important to keep advocating for medical patients and the existence of this program, is because in the whole shuffle of this creating new systems, there can be a lot of really bad and unintended consequences.
And that's, I think, what we know. That's a great, in fact, maybe I have an idea, because we've got about 15 minutes to put on another little thing, write down the points that we know now that if any of these bills pass, what the unintended consequences would be and why. Because I think that the vast majority of the people doing it aren't getting that accurate information. And so that is something we could create and send. That's one idea. And then the second one, if we could, outside this meeting, as the ACMM, one of the things I've noticed, and I'm just as guilty of it as the next guy, that we tend not to all get together again. And if we, even on the ones where we didn't have a voice, if the entire ACMM showed up to any one of these meetings, whether there was a joint committee meeting or whether there was a major 91 meeting, if we all show up in force, that makes a difference. I know that's not easy, but there are events that it's very valuable to take those actions. And so my request is for us to look at those two things. What dates and what events, with Anthony's help and Todd's and everybody's help, what events should we really be showing up for as a collective group? Let's have a legislative conversation. And so I would like to propose those two things as meeting afterwards, not as a motion per se, but just as being in communication, writing down things we can all show up for, and actually just showing up. Because showing up is what seems like it's missing. Let's show up. Let's show up, and then when we show up, let's actually now spend a few minutes and write down the things we want to show up on, and why we want to tell them why it is not workable. Because my guess is they haven't gotten that side of the story. Does that seem like a fair place to go, or I wanted to check? Okay, I'm going to spend just a minute doing that. If you guys want to start by Anthony or anybody else wants to give you the bill or define the areas that are important. What are the top things that we need to tell the legislature? What do they need to know? They need to know about CART, they need to know about they need to know about prescriptions, they need to know about doctors will lose their license if they prescribe.
There's the implicit threat.
The implicit threat, well, that's what I'm saying, but they don't, however, that's what I'm saying, so help me say that. So implicit threat.
Yeah.
Oh, you know what? I'm going to have someone writing that AS has much better definition. Been here before. Thank you so much. So that in smaller communities, implicit, yeah. Threat to MDs to prescribe.
Losing
their.
It's not they're losing the medical license. It's their the ability. I can't remember exactly, but it's the ability to prescribe.
Ability to prescribe. Yeah, prescribe. DA license. That's it. Yeah, DE license.
Yeah.
A prescription DA license. Right. Yep.
Way back in the midst of time.
Actually,
We can't hear you.
yeah, we can't hear you well, and also, yeah.
We very carefully worded the form so that there wouldn't be a threat to physicians.
No, the threat's already there. It's on the other end. It's on the
It's
DA.
a perceived threat, it's not a real threat.
Yeah,
It's
okay.
not, I really think you hit the nail on the head with the malpractice suit. Because back when the
You know what, this will back us off just a thing, because I think we've got this, I want to stay focused on the other agenda items, but, so perceived or real threat to lose the MD license if they prescribe. So the second item is, and that really addresses a lot of the pieces, they don't know that. I would bet most legislature doesn't, and the pain type, the pain management programs, if patients, right, because of that, patients that are on opioids are or that have a medical card are denied opioids. What?
The Liberace's in that thing, or
He's got music in the background.
Okay.
Whoever's on the phone, could you mute? There's music that's coming through.
Is there anybody on the phone? Is there anybody on the phone right now on the line?
Yes.
Someone has music playing, although it's nice.
That's not me.
Okay.
That'd be Brian.
Brian.
That's his background. I'm confused about exactly what we're doing.
Okay, so what we're doing is we're writing down a list of the things that the legislators need to know that will address a lot of the kooky bills, that if they were aware of that, right? So like an example is the one that says more than 450. We know that that won't work, but they don't know why there wouldn't be other doctors prescribing.
They do now, because I tested.
Exactly, they do now, but and that's my point.
I would say that one of the things we should put down is that patients may lose, if they use medical marijuana, they may lose their narcotics, which can put them in a life-threatening situation. I have a letter from a woman who was denied her pain meds if she used medical marijuana. She had to choose between the pain meds or being able to eat, and last that I got from her, she was down to 70 pounds and waiting to die. She couldn't do without the pain meds, and she had to give up the medical marijuana kidney. So this is very
pain
real.
management contracts or
Yeah.
okay.
The pain management contracts. And at the same time this has been happening, the VA had said you can have a pain contract, and if you're legally registered, you can have your medical marijuana. So these people don't know this. The VA, that's federal, right? They've said this is okay, but not the doctors in the states.
That's true. I had a meeting with the department.
Actually, we're going to pause just for a minute, and we will in just a few minutes, actually. In about a few minutes, we'll have public comment. We can talk
I
about
thought this was for everybody.
Oh, do we want to do that?
Oh, you said it was.
Oh, I thought I meant for ACMM.
Oh, okay. Well, I'd like to.
Hello, you want to open it up for everyone?
Yeah.
Yep.
Hello.
Yes.
Hello.
Hello, we're saying go.
Sandy, this is where you need to take that story to the health committee when they hold the hearing on the patient's rights bill, because that's one of the most horrific examples we could come up. And here's a woman whose faith is primarily just to starve to death because she can't get cannabis.
That's right.
So take that to them.
Okay.
Thank you.
So then, do we want, so is that all right if we open it up to the entire, if there's any other suggestions for the entire audience as well? No, yeah, no, if you want to open it up, do you have some coaching? So it's not so much comments on these ideas, but just a specific idea that has specific measurable results for the legislature. Yeah, exactly. Is that specific?
Anyway, what I'm saying is that a lot of veterans believe that they'll lose their veterans benefits if they test positive or if they get a med card or a grower's card, any of this kind of stuff. The conversation I had with the top of the Oregon Department of Veterans Affairs says that that isn't true. So I suggest that we get that information to the vets.
In fact, California just did something and let this happen, and they acted like it was a brand new thing. This whole thing with the veterans happened 3 years ago, didn't it, or more?
It's just misinformation.
And I think we could add this to our list.
So veterans,
Let the veterans get the word out to the veterans that they can have a
that-
card and still have their pain management contract.
And veterans, we can say that veterans, the flip side of that is veterans and doctors, veterans and VA doctors still think that they will not be able to.
Why do we want the legislature to know that?
We want the legislature to know that because they.
Don't we want them to know that in fact the VA won't?
Yes.
The VA will let them.
We'll let them.
Right, that's what they need to know, not
That's
what
what I'm
people
saying.
are afraid of.
Correct.
Yes.
That it should be then extended to all patients and not just.
Yeah,
just
for all
the
that,
VA.
it's just an example, yeah,
If
exactly.
the feds are doing it, why aren't we?
Yeah, that's federal.
Yep. Any other, Kelly?
So I think that this malpractice thing is a big change, because when back in '99 and 2000, OHA was writing cards, Kaiser was writing cards. So I think this malpractice maybe new.
Well, Kaiser was doing it, but then they were sending their patients, in fact, they were the first ones I heard of sending their patients to a pain contract that they signed for. All of a sudden, Kaiser put the kibosh on everything, and you even said you had a medical marijuana card. You were warned by the intake person, you might lose your insurance if you were fitted that.
Well, the thing is, this.
Let me just comment on it real quickly. Kaiser and OHSU have their own insurance schemes. What we're talking about is the CNA Doctors Company Medpro. Those are for the guys that are individual practices or group practices. So that's the truth.
My understanding, the direction that's coming from is the
Yeah, CNA insurance. But say something.
Tom.
Yeah, Todd, yeah.
Preparing the chair. Inclusion of medical marijuana patient advocate on OLCC and advisory and any committees that they create.
That's little detail.
That'll never work.
Crazy.
If we're talking about medical, I think one of the biggest to the legislature, right, is the fact that you can be 21 and over and consume cannabis, but because of that action for childcare, then you can't have a card. I think that is a big education piece for the legislature to understand and wrap their head around.
That's now.
The childcare card?
Yeah.
Okay.
Yeah.
That you can't.
You can be 21 and over and smoke all night long after your job, take care of kids.
But if you're a patient,
But if you're a patient, you can't.
Let's also point out that this was John Kitzhaber's pet.
It was.
And it's time to reverse that in our government.
We all need to send letters to the governor about this.
We can put some statistics up there about how many kids are on the OMP for the pediatric kids that will need these medical cards. I don't think the legislature is very aware of how many kids we do need this card and will not be able to get this card.
All people under 24.
I'm also wondering, maybe aware has insight in this, contacting Kate Brown's office and see where she stands on the child care aspect. And having the current governor's.
Did I hear you correctly that no one in the home can own or possess a card? In other words, if your spouse suffering from a
No, that's not true. Only if you're the caregiver. Would you have a card?
Another point of view that works better. You know, Kate's been generally sympathetic to our efforts over the years. And, you know, if someone doesn't tell her to change the message from the governor's office that was sent by the last governor, then that message is going to be floating around the building. So somebody should contact her and tell her we need to do a message on this subject.
Anyway, we could get a meeting with the governor's office?
I still have one. I'm still waiting for that.
Can't hear you, Larry.
With a name that might be heard in the building before, contact their scheduler.
Can you find Ryan?
Go ahead,
Brian.
Kate being a new governor, I don't even be familiar with her firsthand. It's going to do whatever she can to avoid any initial controversy and bullseye. She came in such a precarious way for her sticker not to have on anything that has the word children on it. Built on Michael. I think our better object would be Ellen Rosenbaum and see what the fuck she heard all this thinking and why, if she wants us to vote for her, she's treating us this way for some good reason. I think that would be our better target. And then if we get Ellen on board, then it's not so controversial for the governor to get on. That's like my sequence of it.
That's great thinking. Well, no, just put in there. Just put there for the child care. Just talk down.
I've spoken with the AG's office on this issue a couple of times, and I've been pushed back every time I brought it up. They're waiting to see what happens.
We were supposed to have a meeting with them and they sent us over.
Well, the one thing is there not, like I checked with Bill on the staff, my understanding is that one of the few sticks we have is that the legislature and Director Hicks is actually required to communicate with us. You know, if we communicate with us, correct? Like they can't just stonewall us, correct? Isn't there a requirement in the bylaws and?
You are right.
In the statute.
The statute doesn't say legislature, it says administration.
It says all agencies.
All agencies.
Oh.
Which includes the legislature.
Exactly, so my understanding is that we can maybe use that card.
Well, above and beyond that, getting that type of an answer from the AG's office, let's wait and see what's happening with legislature, right? What is a good response, such as, well, time is to act now, and we can't wait and see, because we actually have to be actively involved with the legislation that's coming out of the State House. So how do we get a meeting with you so that we're all on the same page to make sure that this program is, taken care of in the future?
And to actually enforce the rules that are all supposed to.
Well, both. But I'm asking the question, what is a good answer to combat that? I'm saying, to try to push you away and say, let's wait and see what's happening in the legislature. Well, no, we need to be active.
That's what I once said, that's why we have multiple branches of government.
Right.
The reason that there isn't just the legislature, but there's also an additional branch is to enforce when activities are taken outside the scope of laws that are pretty legislative. And this is a law that specifically says that, there can't be any action taken against any professionals that hold cards. Like what, did they ever address that?
They did address that, and they skated around it, and they said, this is not disciplinary or civil action, but this is an overall policy shift.
But it's still licensure action, which is what it's directly addressing. It's not licensure.
That's not their position.
See, and that's the position that we have a conversation about. Because that position is crazy, right? You know what I mean? And the reason, and that's what's interesting is that it's getting the conversation.
Yeah.
And so that's why I was asking if there's a way that we can push a conversation. Because I actually made 2 formal requests and physically gone to the state and have talked to the scheduler of the governor when it was given offer and have never gotten a call back. Never had a place. So, and I'm the chair of these. So I don't know, I was wondering if there are actions.
Well, we just have to flood their offices with requests and phone calls until they have a meeting.
Or we all show up.
That's the only way. No, you gotta just start by making phone calls, sending letters, until it starts to come up on their radar. So when I go in and ask for an appointment, they're hearing about it and they go, oh, we've got lots of calls on that, come on in. And, a letter from the Office of the Oregon Medical Marijuana Program outlining their concerns about this contradiction in law would go a long ways in both the AG's office and in the governor's office.
So are you suggesting that the ACMM would need to request a letter from OMMP?
No, we should draft it.
Or ACMM writes the letter? Or both?
I would do both.
Well,
I don't know how the mechanics of that works, but.
She ran away.
She ran away. So, Aaron, do you know what the position is on that? I don't. Okay. Okay, yeah, we got it.
So I don't know what we're gonna do with this.
So we have 10 minutes to work on this. Well, no, my goal on this is just to have something that we can go to. Basically, what I'm looking at is how can we make a difference in the short timelines that we have, right?
So if all of us, if 11 people on the ACMM called and wrote letters asking for an appointment to who, we should say, who are we going to do this to, and all of us do it. Everyone do it.
Who we all do, you call the governor's office and you call the scheduler. Yeah, the
Anybody else?
The attorney general, the governors, I would say are a good start. The
Okay.
legislature sort of.
I'm going to send my letter and make my phone calls.
I would not go through Aaron Knott.
Who?
I would not go through Aaron Knott. He's the one that keeps pushing us back.
Yeah.
Who's Aaron Knott?
He's the legislative liaison for the AG's office.
Okay, so who should we call?
Aaron. I'm sorry, Ellen.
Ellen.
Call her, direct? Okay.
That's a rule.
Is anybody else going to send this besides me?
So let's try this.
Are you?
Do I have a motion?
Oh, let's motion that everybody do it. I can't make everybody do it, but I would make a motion that
if we had the information, maybe what you do is we pass a motion if we want, and then you just said, here's the person, here's the contact information.
Person.
What, we're not gonna
Step out there? Come on, OHA.
And another way to take action is we've got lots of public hearings to come up, coming up. Both with the legislature and the administrative rulemaking that follows. And there are usually 3 seats right at that public where you give your testimony, and they usually call people up in panels. And so if 3 people from the ACMM were authorized to represent these positions and the other list of priorities that we came up with, then we have those people meet before the hearing, sign their names up on the sign-in sheet right one after another, put ACMM as their affiliations, then we'll be right there, and even if they never invite us, we'll just invite ourselves.
So do we need to do a motion to do that, to give authority, or we can just do it?
The other thing with testifying, if you want to testify like all 3 ACMM members in one panel, you need to talk with the committee administrator and tell them your proposed not agenda, but that's what you'd like to do is these 3 people, for instance, when we had 2636, I went to the committee administrator and said, Dr. Sharman is coming from Medford, the other Mel, can't remember her last name, was coming from Medford, Cheryl was coming from Eugene, and you just give the committee administrator and say, this is our panel, and we want them all to testify together, and they'll put you all 3 up at the same time. And then the best way to do it is just the first person does 5 minutes or 2 minutes or whatever you're allowed, you do your 2, and then the next person does the continuation of that, and you, after 6 to 10 minutes, you've had this thread going continuously, and you present your case in that way. Because typically, most people that testify before these committees, aren't very practiced, and it can be really intimidating, so you might just kind of sputter through your 2 minutes. But if you're coordinated in your testimony, Cheryl and I found this to be the case even this session so far. If you're coordinated in your testimony, you should practice it. You should be able to talk for 5 minutes and get 10 minutes worth of testimony.
Yeah. Question. Yeah.
Yep. So then in that vein, would there be one person on the ACMM that would be willing to send an email out to everyone, just instead of everybody relying on figuring it all out themselves, saying, we're all going to show up. This is an event we all need to show up for as much as we can. And we get 3 people showing up and agreeing to someone just spearheading and saying, this is the public engagement.
Could we ask Anthony to do that, because he's on top of it?
Do you know, if Anthony could tell me, he keeps me informed on everything going, if Anthony told me, I would be willing to write to members. Because Dominic can do the work, yeah.
Great, and if you get us days and get us enough advance warning so we can put it on our calendars, let's just try
You need to stop worrying about that and start doing this work right now, right today, as soon as you leave this meeting.
That's
and
exactly.
Then as I keep Cheryl informed on meetings and hearings and discussions and work groups on all these issues, then you can start to coordinate. You don't even have any hearings scheduled yet. So.
Yeah.
Should I discuss that?
No, that's what I'm talking about the future. I know the immediacy, the action, that's thank you.
And I have a note here from, and Tracy can tell me if I just made this out of the whole club, and I'm supposed to write a letter to the ACMM committee. Okay, and so then I've got a bunch of stuff here. What I'm gonna do is I'm gonna write that, I'm gonna send it out to all of you.
The benefit of the
Maybe feedback, yeah. So, okay, good. And then Sandy wants to talk about a way we can all get together.
Well, for years I've been have organized rallies down in Salem, and they've been very controlled. We've had people on the front steps. We've had a private room where people kind of networked out of. We had coffee and tea in that same room. We also had speakers. We had a podium out on one of the steps, and we had speakers. We had a big display inside the Capitol, right where you go to the elevators to the Senate and the House, and a big display there. And then the main thing that we really focused on was getting all the attendees to make appointments with their own legislators. And we've done this year after year after year, very successfully, usually getting at least 100 people to come when it wasn't a big deal. Okay, now it's really a big deal. I think a lot of people are really worried about what's going on. But I'm getting old and I really can't drive. My arm's giving me fit. So I've asked 4 women, Sarah being one of them, Melissa, some other people that are here. Anyhow, if they would, because I know exactly what you have to do and in what order to do it. And I'm offering to do that if I have enough people to really pull it off. And by pull it off, it's a very controlled situation. It's not just show up and lay on the steps with homemade signs. It's not going to be like that. Not at all. And anybody who's seen these in the past know how successful they have been. And I have volunteered to help with this. At this point, we couldn't possibly pull it off until the end of April, just because it takes that long to organize. If any of you are interested in helping, please let us know. We're going to set this into effect immediately. The biggest issue we have right now at the start is what are we going to call it? We have to have a t-shirt, okay, the theme. And we've used marijuana as medicine, patients of the OMMP, we've used all kinds of different themes. We've had several suggestions, and one thing is cannabis is my medicine, period. Or how about medical marijuana lives matter? That was another one. But we're looking for that thing. As soon as I have that, I can start. I can call down and start written everything. The money is not going to be a whole lot. I figure, you know, we have to rent a couple motel rooms because we have to be at the Capitol by 7:30 in the morning. We're going to have costs for the display. We're going to have costs for we usually serve cookies or brownies, and everybody can laugh about that. But anyhow, we have this set up, and I really want to go forward with it. I would love input as far as what to call it.
Do you think we could enlist Dope Magazine? Because that's defending our patients everywhere. Dope Magazine.
No, I don't like that name at all. It has to be something that when a bunch of kids come in with their teachers and they're going by our thing, they're not going to be offended. And that's why it has to be friendly to the public. So whatever we do, it has to be something that is friendly.
And so in that vein, real quick, one of the things is when we're done, we're going to open it up to public comment at this point. And what I would request is that anybody who would like to, if they could just, when this meeting is over, right after public comment, that you guys go talk to Sandy. Anybody who's interested in giving time and focusing on this, I would greatly appreciate that. If anybody wanted to do that. Is that okay? And then Sandy, can you spearhead that from there?
Yeah, I'm going to put a piece of paper out and they can just sign up and give me a contact. That would be the best.
Perfect, thank you. And so now I'm going to open it up to public comment and
First sign up.
is there a sign up sheet in?
Oh, I have a question.
Oh, yeah.
Okay, I would like definition of clarification about this. If I'm a patient and I have 6 plants, and my husband isn't a patient, can he have 4 in my garden? That's a question we're asked repeatedly.
You mean recreational ones?
Yeah, 4 plants.
Yes.
Well, I haven't gotten a straight answer, and I get that question all the time. I'm a patient, my wife isn't, and we have 10 plants together.
That's a question that they're asking.
There is no answer yet.
Brian has answered.
Brian, are you there?
Yeah, I'm right here. Here's the answer I'm going to be glad to give. I'm not sure if a patient can have 6 plus 4 legal, but I'm certain that somebody else in the house can. The legislation will grow for another person. The requirement would be that it's segregated so that it's clearly your 6 plants and it's your plants, and they're not intermingled, so it's not considered that it should be overall 10 plants selected.
So if you put your names on the plant, these are mine 6, and
No, you've got to segregate them, so that have your little garden with a little foamy wall, and you have your garden with a little foamy wall, and he's only tending his plants, and you're only tending your plants.
There has been some discussion about a 12-plant situation where a husband and wife or other family members, so that they can grow their 6 plants each, even in a residential area, so they can have 12 plants on their property, and there's talk about saying that those 12 plants would include the 4 plants that are allowed under the law. So you wouldn't be able to grow 16.
I 6 plants.
The distinction I was trying to make. I don't know if a patient can grow 6 plus 4. But your question was whether or not somebody other than the patient can grow 4 in place.
Okay, that's the answer I was looking for. So if I had 6 plants on one end of the garden and a wall between them and 4 plants on the other end, that would be okay.
As long as there's one adult in the household that's not a car.
Right, gotcha.
Multiple growers at a single location.
So,
They can't collectively be growing all everybody's plants.
so I'm gonna hijack the conversation back again, because we have this long list, but I think it's also for the sign up for the email dispensary report. So instead of trying to read down this entire list, what I'm gonna do is just have everybody raise their hand that would like to make a public comment, and if you could keep it to just 1 or 2 minutes, that would be great. Okay, we'll start, and it looks like, how about, I'm gonna do TK first, and the main reason for that is because it graciously gives us so much time to put this online for the community. Thank you so much. TK?
Thank you for having us. To Dr. Phil Levesque, who helped consign a lot of people's cards. And I was at the Capitol, I filmed it, there was only 2 house people that came down and listened to the testimonies. Anthony was there, I was there, and a few other people further down south. They gave all good testimonies on why a doctor and the numbers in this and that. Money. Okay, the second comment. The OMMP 91. We voted this in. This is the people's decision. And now in the House and in the Senate, they're trying to put these things around over us. Gary's letter to the governor and the other officials is a good comment. When I testified in the second one hearing that day, and that was about 91, the only thing I could say, we voted it in, and don't mess with the medical marijuana, because it's helping the patients. The patient's quality of life is our concern. And I went to the OLC meeting, which was the 91. And that was interesting. They're trying to keep it out of the liquor store and have co with the medical and the recreational. Thank you. We're going quiet, Heidi.
Yes, sir. You might introduce yourself.
Yeah, my name is Dan Dewey. So the information, the word, whatever, the educational pieces, they need to be brought to the legislator, like people going down and lobbying and all that. So my question is, have or can this committee reach out, either in this room or outside this room, reach out to other organizations that were, pro-hemp, pro-medical marijuana, and have them lobby? The reason I bring this up is an organization that I was affiliated, I guess I am kind of affiliated with, has legislative days, and they'll bring down, I think up to 1 hour or 2, it must have been 75 people, and we went from legislative to legislative and representing the groups, and we lobbied on let's approve proposed legislation, and we were successful too. I wonder if that's ever been considered, or is that doable?
Yeah, that's what Sandy's talking about. That's exactly what that.
We've done this in the past.
Yeah, they've
I
done this
understand
past,
that,
yeah.
but with other organizations.
Yeah, that's.
Putting that on an alliance.
We put it out to everybody who's interested and invite them. We have speakers from the different organizations and hopefully attendance by everybody to talk to their own legislators. That's one of our main focuses, is to get people signed up with their own legislator.
Okay, but I mean, having another organization on their legislative day go down and lobby those legislators on their own, but using your, for lack of a better word, talking points to make sure that the message from here through another organization or organizations also gets down to the legislature.
I don't know what other organizations.
Well, there are, there's community, community organizations. I know a couple of labor unions that were not only pro-program, but sucking a lot of money in it too, $5,000-10,000 a week.
I think what you're suggesting is that we find other organizations with common interests.
Yeah,
bringing everyone together.
Yeah, and if that's ever been thought of or figured for.
Well, this committee doesn't really organize lobbying, that type of legislative
So I
work.
should talk to you after the meeting.
Yeah.
All right.
Thank you. And then who was up?
I'd just like something, I'm Debbie Fish. I'd like to say something just simple that myself as a patient and a caregiver, I feel extreme responsibility to educate people, including my doctor, every time I see him. My doctor's private, Cascade Physicians. The way he gets around the whole medicine and marijuana issue is he has a very tight schedule. I see him every 3 months. He is very documented. So if somebody came to him, he has every documentation of our visit. Every 3 months is a lot. So educating the doctors on just keeping their records good is as simple as that. About worrying about the big conglomerations, that day's going to come, but there's a lot of private doctors out there that do have an interest, do believe, and it's our responsibility to educate them as a group and individually, every single day.
And they say bring all your medicines, bring your pills, bring your tincture, bring your salve, everything.
I do.
Your oil.
Yes.
Everything.
I do everything. And he's very receptive, and he's, like I said, he's not a corner doctor here for marijuana. He doesn't even agree with it, but he sees what it does for me, and my educating him has helped him to competently sign my card. So it's our responsibility on a daily basis to educate everyone.
Thank you.
All right. My name's Matt Gompers. I work I'm a distributor in the cannabis business and the alcohol business. And one of the ideas I have, because I'm going around to all the places and just hitting the pavement, was doing a plebiscite. Like 10 years ago, plebiscites to show community support. Like for the medical marijuana thing, I helped collect signatures on it. I had a petition business. I collected all the signatures, got it on the ballot, voted on it. So basically, a plebiscite it doesn't have any legal powers, but it just shows you can basically give it to the legislature or the governor and show them that the public is behind keeping medical and rec separate. And that's one of the ideas I proposed to Anthony Johnson, but I guess he's all about it. So yeah, so that's something I could go around because there's a lot of shops that would like to keep it separate, and if we could get signatures, they can just mail it in. I'd be willing to pass them out when I make my rounds.
Okay, great. Yeah, thank you. Afterwards.
Yeah, no problem.
Got your name?
Yeah, exactly. And then is there, yep.
My name's Ed Bergmans. I'm the CEO of Alternative Medical Consulting. What we do is we have a nonprofit also that is geared towards the veterans. We want to be able to either postpone, reduce, or completely eliminate the use of the opiates and more toxic drugs that are being given to the veterans at this time. And at this point, we're at kind of a crossroads because Columbia County has put a moratorium on any of the medical marijuana practices. They sent out some cards this last Saturday, and my phone didn't stop ringing until 2 o'clock in the morning. Basically what it says is that they're going to temporarily suspend any activity as far as the medical marijuana industry goes in Columbia County. So Sunday I showed up at the state capitol. I've had quite a few conversations with senators and state representatives about what's going on. And Tuesday morning I had a 2.5-hour conversation with Columbia County Commissioner. He told me that the reason that they put the moratorium on is because 91 is going to put all these laws out, and they're required by law to start writing laws as soon as 91 got passed this last year. I don't really believe that. 91 was written that it was not to affect the medical marijuana industry at all. So why do we need to suppress the medical marijuana industry and keep people out of business? I know one individual that has a dispensary. It's been ready to go for months. And the county claims that if we give that person a license, we're liable later on if the laws change. And so I talked to this individual, and this individual told me, he says, well, I'm willing to take my chances. And so I think there's a definite violation of people's rights in Columbia County. I'm going to try to mediate the thing out and see if they'll actually come to their senses and try to educate the county commissioners about what's going on with the medical marijuana industry and what they need to expect. My company's setting up a working structure for people to actually be able to turn in pot, have it tested, pay their taxes, all in the same location. And our idea is that if we have a palatable price for the entire industry, not only the person that grows 4 plants or 40 plants or 4,000 plants, it all goes to the same testing facility. Your taxes are taken out. So what this does effectively, it crushes the black market. Even the medical people that need to support their activities have a place to get the cash out of it. There's still a lot of small details to be worked out, but I think we can, through education, curve around a lot of these things. And it really is about teaching people. The growers that I've seen, 70%, maybe 75%, really shouldn't be grown because they need to be taught. And I've seen some pretty horrendous things. Cats using pots as litter boxes, for instance. Fungus that's an inch thick on top of the plants. And it's not that these people don't try, it's just there's no place for them to learn. So what ends up happening is they go to a local grow store, indoor grow store, and they ask the kid that's working there. Well, he doesn't know. But that's their source of that, between a couple of 2-3 books that are out on the market. My company has started a teaching seminar that will teach.
You know what, we're about 5 minutes over now, so if you want to, was there anything about, like, less with your company and more with
well, I'd like everybody to get on the bandwagon as far as the counties are concerned. The indication that I got from the county commissioner is that as long as we feel that our resources are strained, we can put a moratorium on it. I'm afraid that that's going to get passed on to counties, so I'm trying to, at this point, put a stop to that.
Sir, I actually have that question into 2 attorneys that say not only is it unfair, it's illegal. So I wouldn't fret too much about that because we are protected under the medical marijuana law, and 3 commissioners cannot decide that we should stop growing for 120 days. Well, they can't. It's illegal, and also.
Well, so guys, I hate to hijack this conversation, but I think we can have all this afterwards, and I would love for anybody who wants to stay around a little bit and have that conversation.
Read the law.
But, oh gosh, thank you, Steve. So there's one other thing. You remember those great booklets, the handouts that they were talking about? These 2 here. I know there's more than one person that works with other patients, caregivers, and growers. There's boxes down here full of each one of these brochures. Please take as many as you can distribute confidently, not to just take them and circular file them. But my request is that you please take them and get them out to people, because it would be very, so one, this is the Oregon Medical Marijuana Program handbook, specific how it works. It's just been updated. And then two, this is the qualifying for reduced fees. These two are very valuable. So anybody who's working with patients, please feel free to come grab these. They're available. So, thank everyone.
Is the Spanish one in there too?
That's on the, so that is.
Spanish is on the way.
Translated right now. And the new forms. So the new forms are also going to be translated. All that will be on the website. So you can
Will be Belgian?
There will be Spanish versions.
Oh, was there other people over here? Oh, I didn't check. Were there people over here? I looked at one side. Before I go, is there anybody over here that needed to speak? I forgot. Was there a hand up here? There was.
Just one.
Yeah.
Kind of a sticker for everybody.
Yep.
But to get a hold of Ellen, get a hold of her husband.
Get a hold of her husband?
Yeah. He works for he owns the Lamb.
That's right.
You have to put a hot seat underneath.
Yeah, thank you, sir. Great.
Yes.
Oh,
And everybody, if you haven't seen the website, please check it out. There's a lot of information on it. And one thing that you might not know about is we started updating the status of where we are processing applications on the front page. So before you call, check that.